Now please start.
Good evening, everybody. On behalf of ICOG, I welcome you all to the masterclass on explaining the unexplained. The quest continues. We would have 5 talks and would be followed by question and answers. And I would request all of you all that they post their questions so that they would get their answers. I would request Dr. Lakshmi Shrikande to say a few words before we start the session.
Thank you. Thank you so much, Madhuri. Very good evening to one and all. At the outset, I would like to place on record my sincere thanks to FOGSI President, Dr. Rishikesh Pai, Secretary General, Dr. Madhuri Patel, and all the FOGSI office bearers for their constant support and guidance for our all ICOG programs. I appreciate the efforts of our Vice Chair, Dr. Parag Biniwale, Secretary Ashok Kumar, and our convener, Dr. Madhuri Patel, for bringing out this short module. I know it's a very, very vast and exhaustive topic, but they have brought out this short module on unexplained infertility. I also take this opportunity to welcome all our speakers, Sujata Kar, Deepak Modi, Nirmala TS, Sonia Malik, and Pratik Tambe, along with all the 4 chairpersons, Dr. Rita, Dr. Shobna, Parikshit Tam, Chaitanya Shimbekar. Friends, we all know unexplained infertility is challenging for clinicians and frustrating for the couple. Madhuri has only taught to our ICOG students that the incidence of unexplained infertility decreases from 15 to 30% if these couples are evaluated in a very, very meticulous and systematic way. But once labeled as a case of unexplained infertility, they do need evidence-based treatment. But of course, personalized, individualized approach plays a great role as far as fulfilling their dream of parenthood is concerned. So Madhuri, thank you so much for coming out with this module on Masterclass where you are covering the key aspects from clinicians' point of view so that they will find it easy to manage unexplained infertility in their day-to-day practice. So dear delegates, I welcome you all. Let's have happy learning from all the masters, including Master Dr. Madhuri Patel. So back to Madhuri for further proceedings.
Thank you, Lakshmi, for giving me the opportunity and being here with us and doing several programs for ICOG. I would now invite our chairpersons for this session, Dr. Rita Bilengdi, who has a fellowship in reproductive medicine, and she's a senior fertility specialist at Cloud9 Bangalore, and Dr. Shobna Patel, who is a director at Patel's Fertility and Research Center, past chairperson of Karnataka chapter of ISAR, past president of Karnataka Society of OBGYN, and executive committee member of PCOS Society and a secretary of Fertility Preservation Society. And she has several research to her credit, and I hand over the session to them.
Good evening, everyone. Thank you very much, Madhuri, for that introduction. I welcome. As you've heard already, the incidence of unexplained infertility can vary somewhere between 25 to 50%. And the diagnosis is made when there is no apparent cause found either in the male or a female reproductive system. Basically, it's a diagnosis of exclusion by standardized investigation, what we do. Having said that, we all know that there's no real standardized diagnostic workup which is available for these patients. And even if we do, there are certain fertility processes which cannot be picked up by our test. Just for an example, all patent tubes need not be functional, like that we know. And also a male factor can be present in spite of a normal seminal assay. So to talk about this and more, and we have 3 speakers in the first session. Dr. Sujata Kar, Dr. Deepak Modi, and Dr. Nirmala TS. I now call upon Dr. Sujata Kar. Dr. Sujata has several accolades. She's been a best graduate and she has won 7 gold medals in MBBS. She has been credited with the first IVF baby in Eastern Orissa. She has first laser hatched baby of Orissa. And she has been, her center has been the best IVF center in the last 2 years. She has several excellence award in 2018 for the best IVF center, Parichaya award for the Woman Achiever, Devi award, So she has several awards to her credit, and she has 14 original publications. Mainly, she's working in the field of PCOS and male infertility, and she has also written many chapters for books and newsletter. And she's a reviewer of many international journals and honorary treasurer of ISAR. And her special area of interest, all of us know, that's polycystic ovarian syndrome. And also she's working on stem cells in gynecology. And we look forward to hear from Dr. Sujata. Sujata, over to you, please.
Thank you so much, Shobna, for your introduction. As I start, I would like to thank the FOGSI, especially FOGSI President Dr. Rishikesh Pai, your Dr. Lakshmi Shrikhande, and Dr. Madhuri Patil for giving me this opportunity in ICOG Masterclass. And the topic is also very interesting, unexplained infertility. I am supposed to talk only about definition and diagnostic workup, which tools, what we can use for the diagnosis of unexplained infertility. And I think Socrates, this saying, which says, all I know is that I know nothing, applies best for unexplained infertility. So some fertility stats, interesting stats we all know, but I thought I should share it with you. In general population, couples attempting conception, 84% will conceive after 1 year and 92% will conceive after 2 years. Each additional month of infertility beyond the average reduces the chance of pregnancy by about 25% per year. For each year of the female partner's age beyond 30 years, the pregnancy rate is reduced by 9%. Every year, 99% it reduces. In unexplained infertility, average cycle fecundity was found to be barely 3.8% in one study and 1.8% in one study. We know that human fecundity as such is low, but it is quoted typically as 18 to 20 per cycle. But in this category of patient, it was found as low as 1.8. And prognostic factors related to higher cumulative pregnancy rate in any couple is thought to be duration of infertility, which should be less than 2 years, a previous pregnancy with the same relationship, and a female age less than 30 years. So like Dr. Shobna said in her introduction, in unexplained infertility is usually a diagnosis of exclusion. Rather, it is a lack of diagnosis. And it is made in couples in whom all standard investigations are negative. And it has been, the incidence varies a lot based on the study and based on the population type, prevalence varies. It has been reported as 8 to 37%, but recently as high as 50% also. So even highly sophisticated tests, whatever are available, whichever situation, whoever can do, if it fails to detect, it can fail to detect very subtle abnormalities which are responsible for subfertility. So it can vary as much as 50%. And if you are doing good tests, all the possible tests that you have, maybe you can reduce it to 15% or 20%, but still there's a large chunk of patients whom we do not know what is the cause. And typically the definition is, if these three criteria are met, the patient is the couple is taken as unexplained infertility. So if the woman has normal ovulatory function as established by means of either basal body temperature, cervical mucus changes, serum LH hormone surge, or mid-luteal progesterone levels, or evidence of follicular rupture by ultrasound, semen analysis is good, at least by the updated or WHO 2010 criteria, and tubal patency is established by either HSG or laparoscopy. If these three conditions are fulfilled, we can take her as unexplained infertility. These are by the ASRM, RCOG, etc. Guidelines. Now, I'll just go in first to show how we can reach at this diagnosis, what all evaluation we should be doing, tests, etc. And then towards the end of my presentation, I will share some of the possible causes as to why we cannot find why the couple is not getting pregnant. Now, this is very standard. I will not bore you by talking too much. Evaluation of the female partner, taking history, menstrual history, obstetric history, previous contraception uses is very important, and previous pregnancy loss is very important. And if she's ever had a pregnancy with the same partner, that also is very important. Coital history, frequency and chances of ejaculatory or these kind of dysfunction is very essential. Past surgical history, medical history, history, family history, all these are previous treatment history. If she has undergone personal history like smoking, alcohol, drug abuse, we know now that the exposure to environmental toxins and occupational hazards. So that is also very important. And on examination, the BMI, hirsutism, galactoria, thyroid swelling, etc. And a good pelvic examination, clinical examination is essential. And then we do at least these 4 tests, which is tests for ovulatory dysfunction and ovarian reserve. These days, almost all of us will do some form of ovarian reserve testing, also other than ovulatory function, husband semen analysis, test for tubal patency, and a good ultrasound of the pelvis. Now, ovulatory dysfunction, we know theoretically all these can be taken, which is a regular menstrual history or serum progesterone, urinary LH, transvaginal scan, endometrial biopsy. But we know that for all practical purposes, endometrial biopsy is out. We don't do it. Serum LH search can be expensive and difficult to time it. Menstrual history is good, but you can still have an ovulation even with a reasonably good menstrual cycle. And so transvaginal ultrasound to demonstrate directly rupture of a follicle is, I think, in practically speaking, one of the best ways to detect ovulatory dysfunction or ovulation. And mid-luteal serum progesterone, of course, for all theoretical purposes is taken as the standard. Now, test to assess ovarian reserve, we have day 2 tests like FSH-LH, we have AMH, and we have antral follicle count. All of them have their pros and cons, and we know all that. I don't need to go into that in this talk. Now, whether to do HSG or laparoscopy, that is a clinician's dilemma, and very often people keep asking, in discussions and all, which test should be done. So, although there are set criteria, I would say HSG is the screening test which should be done as a first-line investigation in any woman who does not have any abnormality as found on a good transvaginal ultrasound. Laparoscopy should be reserved for a woman who has any morbidity or any abnormality that you find on a vaginal ultrasound, or who has a history of previous surgery or suggestive or anything like that, or who has a HSG which is abnormal. In these situations, we can do a laparoscopy ahead of doing a HSG. Now, I want to show you 2 vaginal ultrasound pictures. The first one is a normal pelvis. So the person who does the first evaluation by pelvic ultrasound transvaginal is very, very important, because that gives you so much information about the position of the pelvic structures, the uterus, chances of adhesion. You look at pouch of Douglas, you elicit tenderness. There's so many things you will know from a ultrasound that will suggest to you some subtle abnormalities which otherwise many people who do a scan may not be able to mention. Look at this scan. It was absolutely normal and gives you confidence that laparoscopy is not going to show you anything more. But look at this ultrasound. When you do, the uterus is retroverted, appears to be fixed. The pouch of Douglas is totally obliterated. Left ovary is so close to the uterus, it appears to be stuck to the uterus. There is some amount of adenomyosis. The posterior thickness of the uterine wall is more than that of the right wall. So these are some subtle findings when you find, although the uterus is almost normal size, the ovaries are almost normal. So these are the little things that you will have to look at when you're doing a good vaginal ultrasound. Now, having said that, there is one more thing which we have to keep in mind, which is that the tubo-ovarian relationship is the only thing which can only be judged by a laparoscopy. A good ultrasound will not show you. A good vaginal ultrasound will not suggest to you. HSG will not. You look at this patient who has a absolutely normal, clean pelvis, no adhesions, nothing. Ultrasound is normal, HSG is normal, everything is normal. But when you do a laparoscopy, you realize that the tubo-ovarian relationship is totally abnormal, because the ovarian ligaments are very long, the infundibulopelvic is very short, and it has pulled away the ovaries, and the tubes are adherent and they are facing towards the liver, towards the upper abdomen. So no way this tube will be able, although it's completely normal tube, there is no way it can do its function by doing the pickup of the ovum, because it's simply not oriented towards the the ovary. Also, sometimes there are para-ovarian cysts which completely distort the direction of the tubal fimbria away from the ovaries, and so they cannot do. So laparoscopy is, in rare situation, you will understand, is the only tool by which you can judge the tubo-ovarian relationship. Now, evaluating the male factor, again, there was a time when we used to think 20% of infertile couples, and maybe in unexplained infertility 30 to 40%. But now we know that as slowly environmental factors are increasingly becoming important in causing male infertility, we know that males may be contributing 50% or if not more for both infertility and unexplained. So again, history, etc. is important. Medical, surgical history, if any surgeries have been done, exposure to gonadotoxins, previous chemotherapy, occupational hazards, alcohol, smoking, drug abuse, sexual history, coital difficulty. Sexual history is very important, which we very often don't elicit. And when we give our assistants or our juniors to write history, they do not often go into the details of sexual history, but that's very important when unexplained, because you'll be caught by surprise that sometimes even after 9 years, 10 years, there will be a non-consummation of marriage. So that's important. Now, what drug history, etc. And physical examination of male also, which is something which we are very much, we don't pay too much importance, but because especially as female gynecologists, we tend to, sometimes, in fact, we don't do it and we don't give that much importance. So even the seminal fluid report might be, kind of normal, but the patient may be having many reproductive, issues like varicocele, hydrocele, or, problems with seminal vesicles, etc., which should be judged by a proper thorough clinical examination. Now, seminal analysis, I'm not going into detail. We know that the revised, updated WHO 2010 parameters should be looked at. But one thing is that if you find a subnormal or not a very adequate seminal analysis, or you're not sure it's falling in the borderline, a good method to judge for the seminal fluid is to look at the post-wash motility and total motile sperm counts to be able to judge whether that sperm semen sample is reasonably all right or not. Now, these are the standard tests and a good transvaginal scan. Now, after these routine tests, there are some tests we should, I think, in this day and time, we should consider whether they will help us in evaluating a couple in which we do not find any cause doing these 4 routine tests. There are some papers now which are being reported about sperm DNA fragmentation, whether it has any role or not. And this was a very recent paper which showed that in cases of idiopathic unexplained infertility, if you do sperm DNA fragmentation, now this is not proven. But then Madhuri told me to speak about tests which might help. So yes, this could be one test which will probably show up with enough evidence in the near future about seminal fluid. Now, because we know that seminal fluid analysis is really lacking behind, we know we don't have any good test to check for semen function, or rather its potency. We just do not have. So sperm DNA fragmentation could be one. And then this was another publication, and this test is also slowly going to come up in maybe in a year or two. We will have clinical tests in our armamentarium to be able to check for sperm RNA elements, microRNAs or mRNAs, which reduce the chances of live birth or chances of even fertilization, etc. So this is another aspect of idiopathic male infertility. Now, office hysteroscopy, is a hysteroscopy indicated in cases of unexplained infertility? Now, we would say that if the transvaginal scan is good, it's showing no abnormality, there is no need for doing office hysteroscopy. I know that evidence does not support it in cases of a cohort of patients which is for IVF. But for unexplained infertility, we do not have much data. But so my question is, should we look for, COGS, genital COGS in all patients of unexplained infertility? There are papers from North India and a couple of other countries also which believe that all unexplained infertility patients should be evaluated for genital COGS by doing a hysteroscopy, taking a biopsy, or sending for culture sensitivity of Mycobacterium tuberculosis, and chronic endometritis. This is another condition which is also coming up a lot, whether it is for evaluation of RPL or recurrent implantation failure or for unexplained infertility. And so hysteroscopy will be able to give us an idea, because with hysteroscopy you can find micropolyps, strawberry endometrium appearance, and in histopathologies, plasma cells, and even immunohistochemistry can tell you if there is chronic endometritis, and that can then be a cause for unexplained infertility. Then finally, is there a role for uterine artery blood flow studies in unexplained infertility? Again, we do not have much evidence, so I will not speak much about it, but it is possible that, because you see, we know that recurrent pregnancy loss, recurrent implantation failure, and unexplained infertility, probably there is a common path somewhere, common for all three of them. Some portions, at least some percentage at least, of patients who might be in that in a common grounds, which for one reason they are not able to either fulfill any one of these criteria. So what about dysmorphic uterus? What about the requirement for doing a 3D scan or a hysteroscopy to look for T-shaped uterus or a I-shaped uterus or a Y-shaped uterus? There are proponents of dysmorphic uterus who feel that yes, this is a cause, can be a cause for infertility, although on a routine scan or otherwise it will be totally normal. And again, the evidence for dysmorphic uterus which is published is mostly in the cohort of patients which are for IVF. But we do not have enough evidence in cases of unexplained infertility. So yes, dysmorphic uterus, also looking for them either by 3D scan or by a dysmorphic uterus, typically a T-shaped uterus, by doing lateral metroplasty is shown to improve at least IVF success. Now, inadequate luteal phase, this is very, very controversial, so I'm not going to go into it. But there are situations whenever we have unexplained infertility and we try to give them ovulation induction, expected management or ovulation induction, and then we do give them support with luteal phase, hoping that that might help the patient getting pregnant. So after evaluating a patient and looking at the minimum tests that we should be doing before we brand our patient as unexplained infertility, the last segment of my talk is what could be the possible cause. Because it is basically we are unable to identify, because there are so many factors which we cannot see and cannot test. So subtle reproductive abnormalities like endocrine, genetic, immunological disorders. So these are some of the areas which can be researched more to look for factors that are responsible for unexplained. Basically, the problem with us is that we are unable to identify subtle reproductive defects, and possible causes may be minimal, mild endometriosis, compromised ovarian reserve, and natural fecundity may be less than normal for some people. So that is why they will spontaneously get pregnant after 5 years or 6 years of being together. And uncommon defects, genetic, immunological, endocrine, etc. In endocrine, various thyroid abnormalities, HPO axis abnormalities, pituitary tumors, Cushing's, adrenals, genetic, like a wide range of chromosomal abnormalities, single gene disorders. We know about the X-linked fragile X syndrome, etc. Multifactorial inheritance also may be there for both males and females, and therefore a family history also becomes very important to evaluate a case of unexplained. Immunological, like autoimmune diseases, we know we have situations where the body can produce autoimmunity against the ovaries, antiphospholipid syndrome, vasculitis secondary to diabetes, SLE, etc. There could be many unexpected and unknown causes that can lead to unexplained infertility, recurrent pregnancy losses, etc. Those are the type of abnormalities that can lead to premature ovarian insufficiency, endometriosis, PCOS, etc. And of course, there are many peritoneal, tubal, local factors we know which we can't explain, like you say, bad egg quality, bad embryo quality, various abnormalities in the sperm, etc. And whether it is subtle differences in the peritoneal environment. So these are all unknown factors which we don't know, biochemical reasons, etc. We don't know. So now lifestyle and environmental factors are also now becoming important, because they are slowly gaining more and more importance with so much use of polyaromatic hydrocarbons, polychlorinated bisphenols, dioxins, nitroaromatics, so many such compounds which we are using on a day-to-day basis, which are xenobiotics, are fat soluble, and therefore readily taken up from water, sediments, and food sources in the tissue of organisms. And we know those are one of the major causes of male fertility decline over the last many years. Apart from that, there are many professions which are at higher risk, like anesthetic gases, etc., anesthetists, dentists, etc. Prognostic factors are maternal age, duration of pregnancy, previous obstetric history, risk factors. So when we find no cause for unexplained infertility, we have to give good enough reason for our patient. We have to tell them these could be the reasons, unexplained reasons why you're not getting pregnant. These are the risk factors they should know. We don't know how and why, but they should know that these are the 4 risk factors. Maternal age, nobody can look into. We know that maternal age reduces egg numbers and egg quality, but now we also know that it reduces endometrial receptivity. So the chances of getting endometrium being at fault and not getting pregnant at a higher age is high. BMI in IVF patients have been well studied, but BMI is certainly a risk factor for unexplained infertility, just like smoking and stress. So smoking by cigarette, toxins that can disrupt corpus luteum. These are direct studies that are published, and we have evidence to show that it can impact implantation of the embryo also. And stress by raising cortisol has been shown to reduce immunological markers, and therefore possible that stress, etc., also is a cause for infertility, at least for these are. So the point is that we have to counsel our patients, ultimately make them understand that these could be factors. I'm sure in the next few lectures other speakers are going to speak about how are then we going to manage, because it's all about managing. You'll do some tests, some extended tests, whatever you feel is having sufficient evidence, but ultimately you have to do some procedures, IVF, unexpected, ICSI. I'm sure the other speakers are going to speak about it. So let me end my talk by giving you some key take-home messages. Unexplained infertility, unfortunately, is common. Prevalence may be as high as 50%, but may range from 15 to 37%. A uniform definition of unexplained infertility is needed at least for research purposes. At this time, we will only do a test for ovulation, a test for semen analysis, and a test for tubal patency. But there are different countries who would do different tests. I know for sure that in many European countries, they just do chlamydia testing, etc., and with that only they judge whether there's tubal patency. They don't even bother to do an HSG or a laparoscopy and all that. So, and also there is a need for research to identify more subtle causes of infertility. And we are sure that the future is personalized medicine, which may greatly affect the future option for evaluation and treatment of the couple. Unique genomic, epigenomic, and other omic characterization of the female and male partners that will become available will help us better to understand and manage unexplained infertility. Thank you so much. And I take this opportunity to invite all of you for 2024 annual ISAR in Bhubaneswar.
Thank you. Thank you, Dr. Sujata. You were wonderful as ever.
Thank you.
Very vast topic, and you covered it very beautifully, highlighting the salient features. When it comes to actually unexplained infertility, the problem is always in the younger age. We all felt in our clinical practice that if it's an older couple and they have gone to many centers and all possible tests, whatever is available for us in clinical practice would have all been done, and they would have gone through a few cycles of this and that before they come to IVF centers. And then there's no dilemma. It's straight away going for IVF. But when they're a little younger age and then married for not a very long time, the couple they're not obviously ready for IVF. That's where unexplained infertility really is bothersome. And as Dr. Sujata mentioned, it's very important. She highlighted the importance of doing diagnostic laparoscopy in some of them. So we normally tend to think that if they're properly done HSG, there's no need to go further, but no. I think in that age group, liberalizing laparoscopy and hysteroscopy and tests through tuberculosis is all important. Maybe some of them we may feel that, okay, it may be worth trying IUI with better ovulation induction with gonadotropins and things like that. So in younger age, it's very, very important to liberalize some of these higher end tests. And coming to genetic and immunological tests, we still have some way to go. A lot of basic research is yet to happen, and where we can really identify some of the unidentified causes as of today. Thank you, Sujata.
Thank you.
We'll move on to our next speaker now, Dr. Deepak Modi. Deepak Modi is very popular speaker in whichever conference he goes to. And then he's, can I have his CV, please, to introduce him? I know that he's a great scientist. He's the one who has become popular among clinicians coming from advanced research labs. Long CV. Wow, he's a PhD in human genetics, elected fellow of National Academy of Sciences of India in 2020, presently scientist at the ICMR National Institute for Research in Reproductive Health, and heads the Molecular and Cellular Biology Group. The recipient of so many awards, including PM Bhargava Oration Award. Wonderful. He has 125 publications. He's so young. You can imagine how many more he'll publish. Current research areas, understanding of mechanisms in embryo implantation, wow, and placental development, placental functions and dysfunctions, genetics of sexual development in male infertility, wonderful, COVID-19 and reproduction, and co-investigator of the pre-COVID registry, which collects information on pregnant women with COVID-19 and their babies in India. Super. Over to you, Dr. Deepak.
Thank you so much, ma'am, for a wonderful introduction. And I'm so grateful to Dr. Madhuri Patil for actually inviting me for this very interesting event which happens, and I enjoy being here. And I'm also thank Dr. Sujata for setting the stage. I agree with Dr. Sonia that she's really put the stage and made my life much easier, because then I don't have to talk about too many introductions and backgrounds. So let's straight move to what is a father's contribution to unexplained infertility. When we talk about unexplained infertility, is a favorite diagram most of us have, that half is men and half of women, and about a fourth is what we cannot explain. And again, it's among them, it is believed that one half of them could be because of the male factor, unidentified male factors. So what are these so-called unidentified male factors is what I'm going to talk about in the next few slides. But before that, let's talk about what's the prevalence. And these numbers have been moving around in all different directions, from as low as 5 to 10% to as high as 50% in that group of couples whom we don't know why they're infertile. And getting to it, this is some data coming from our institute. This is a 10-year data which was published in JHRS late in 2021, where we could show that in about 38% of couples, we just cannot explain why they're infertile. So this is a secondary reference center where these infertile comes for evaluation, and this is the data from about 1,000 couples, and at about 38% of them, we just cannot explain the cause of infertility, implying that it is a big problem. And as Madam rightly pointed, that these are young couples who come, who are not yet ready to go for IVF, and when they come for evaluation, almost 40% you will not know what's the problem. So it's an important problem. It's a problem which we need to understand, and let's understand how much of this is being contributed by the male. So when we talk about male factor infertility, as Dr. Sujata mentioned, that we need to even define this appropriately. We don't even know how to define unexplained infertility. So the textbook definition tells us that a male factor infertility can be classified into two categories. One is what we call it as idiopathic male infertility. These are infertile couples in whom there is a problem with the male partner, but the cause of that problem, semen analysis, abnormal semen analysis, is not known. So that's definition one. You come with a couple, the couple has come with a semen analysis report, you find this azoospermia, oligozoospermia, blah, 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 but you do not know what are the causes of that. The second category is is where the male partner has normal semen parameters, but yet we don't know. And what I'll be talking is about what all is known about these two categories in two separate conditions. So please remember, my slides will flow into, first I'll talk about idiopathic male infertility, where there are abnormal semen parameters. What are the causes of that? The second section of my talk will determine whether semen parameters are normal, but still it could be a male partner, which is a problem. And this problem is arisen because of the way WHO defines male infertility as. It says that male infertility can be said when you know that there is abnormal semen parameter. Do this quick test there and you will know that, okay, there is an infertile male. I feel that is too frugal, that's too superficial, applies well in a broad context when the couple presents to you at a clinic with infertility, but it's not wise to stop it there because we need to investigate the causes. So why this definition is needed, as Madam said, number one, we need to understand pathophysiology, and the pathophysiology between these two conditions, these two definitions is very, very different. Here, one, the pathophysiology is an abnormal spermatogenesis process. In the other case, there is probably a functional defect in the sperm, which is not allowing fertilization to occur. And because of the differences and underlying pathophysiology, the test that you may want to recommend in these two conditions will differ significantly. It is also necessary to provide an explanation to the couple why they're having a problem. Often when the couples come, you would better understand than me that they'll ask you, Dr. Saab, why there is an infertility. Number one, why my sperm count is low or why my sperm count is absent. You need to answer to that why in the first category. In the second category, they'll say that my sperm count is normal, but still why am I not conceiving? And you need answers for that. And of course, these answers, you need to provide the couples a realistic idea for the chance of a successful pregnancy by a natural cause or by a assisted reproduction. And finally, it's going to aid couples in making very difficult decision-making regarding the reproductive treatment, whether they should go for an ART or not. Extremely expensive, not affordable by many in this country even today. And then the couples need to know where they're going wrong and what are their options that they need to be taken care of. So let's move to the first category, idiopathic male infertility. A reminder to everyone that here the semen parameters are abnormal. So clearly falling into the category where it is an infertile male. The idiopathic factor is where there is no known cause of altered volume, altered pH, or altered viscosity. This is not something which we pay much attention to, but this is also a significant proportion of couples where we really don't know what are the causes of them. Generally, we know enough about altered counts and motility like azoospermia, oligozoospermia, oligoasthenoteratosis, or there's something called as multiple morphological abnormalities of sperm flagella, MMAF. This is a new category not yet introduced by WHO, so your classical semen analysis report will not give you a diagnosis of MMAF, but you must ask that is there any evidence of abnormal sperm tails or abnormal sperm flagella? How many of, so they'll typically be classified under oligoasthenozoospermia or asthenozoospermia, but asthenozoospermia is a very nice looking sperm, very nice looking tail, but there'll be evidences where there'll be constant curl tail, short tail, stub sperm, very short tail. Now, these are something which you have to ask your pathology labs to tell them that are there any abnormalities of sperm flagella? Why? I will tell you in next couple of slides. So when you encounter a male where you do not know what is the cause of azoospermia, so you're ruled out mumps, measles, you're ruled out other previous exposures to cancers. Now you have a sperm male who has azoospermia or severe oligozoospermia. The first set of investigation as a couple you will do is do karyotyping for both the couples, because in about 10 to 20% of them, the causes are abnormal karyotype. Why that karyotype information is necessary, I'll tell you in some time. The other test which you will do along with the karyotyping for the male partner is do Y chromosome microdeletion testing. Now, the karyotyping, if it is abnormal, you have to counsel the couple that, okay, you will most likely not conceive naturally and you have to go for an ART. And the ART is also not going to be a linear process. You have to counsel them for having an option of PGTA or PGT-SR, because a good proportion of the embryos will be abnormal. And even if you put repeatedly, you'll put and you will experience, they'll be classified as recurrent implantation failure. But the implantation failure is because the couple is having abnormal karyotype and the resultant embryos are genetically unstable. So your option here is whenever there's a couple with abnormal karyotype, you have to counsel for ART, followed by ART. It has to be along with PGTA, PGT-SR. Of course, you have options of donor semen, donor oocytes, and so on and so forth, which I'm not going to get into. Now, when you come to Y chromosome microdeletions, about 10% of men with azo or severe oligospermia will have a Y chromosome microdeletion. Now, in this case, your counseling will differ. You have to tell them that all the males conceived post-ART in such conditions will be infertile because a father is going to give the same genetic defect to the baby. Number two, all of these men with Y chromosome microdeletions will not succeed very well in ART. So if they want to choose the ART, you need to tell them that your chance of successful sperm retrieval is going to be low. Your chance of getting good quality embryos is going to be significantly low. And all these men with Y chromosome microdeletions also are risk of other diseases like cardiac disorders, like lung cancer, like neuropsychiatric disorders. And this counseling needs to be done. Now, when there is no Y chromosome microdeletion, which is going to happen in about 70% of your unexplained male infertility cases, or idiopathic male infertility cases, you will need to do exome sequencing, because what I forgot to tell you was that almost 50% of these cases will be because of a genetic defect. And diagnosing this genetic defects becomes crucial because that will help you in genetic counseling. So you do exome sequencing. If you identify pathogenic mutations, you have to subject them to genetic counseling. And if there's a pathogenic mutation is going to cause any other defects in the baby, then PGT-M is going to be your option. Now, if there is no further things identified, no further testing is needed, then you strictly label them as idiopathic male factor infertility. But again, as I said, that when you look at multiple morphological abnormalities of sperm flagella, that is MMAF, then you have to straight go for exome sequencing. You don't need to go for Y chromosome microdeletion testing. And in this, the kind of genes which are involved in the men without Y chromosome microdeletion testing, but azoospermia or oligospermia versus MMAF, they're completely different. These are genes associated with motility and centrioles, whereas in this case, the genes are completely different. They are associated with meiosis. And the genetic lab becomes very helpful for the genetic lab to differentiate between these two phenotypes to get appropriate results. Now, when it comes to azoospermia, please remember that you need to classify whether it's obstructive or non-obstructive. If it is only non-obstructive azoospermia, that you'll go for karyotyping and for Y chromosome microdeletion testing. But if it is not, I'm sorry, this title is wrong. If it is obstructive azoospermia, then you have to do CFTR gene mutation testing. In about 80% of men, you will identify a CFTR gene mutation. If there's a CFTR gene mutation identified in an obstructive azoospermic man, then you have to screen the spouse also for CFTR, because if both of them are carrier of mutations, then you will have a baby which is at a very, very high risk of developing cystic fibrosis. Please remember, the cystic fibrosis is a very high risk factor for obstructive azoospermia. So it is important that both the couples are screened, and if there is a CFTR mutation identified in both the couples, then you have to do a genetic counseling and offer them PGT-M or prenatal diagnosis to rule out cystic fibrosis. If the mutations are not identified, you don't need to do much testing. If you follow this algorithm, you'll explain the cause in 90% of patients, and you realize that this is essential, that if there's a CFTR mutation testing, the counseling and management differs significantly as compared to the patients without CFTR gene mutation testing. Studies from my colleague, Dr. Rahul Kajbire, has indicated that in about 8% of couples who have obstructive azoospermia, there will be a CFTR gene mutations in the female partner as well. So you are now giving an infertile couple a risk for the baby, but the baby might have cystic fibrosis, which again, you don't want. So to have a healthy practice, this kind of algorithm following is very essential. Now we will switch gears. We are now going to spend time about understanding what are the unexplained causes of male infertility, which is going to be somewhat around the other 50%. Now there's a couple who has come, and the male partner has a semen parameter which is normal as per WHO standard, and you don't know what to do. Now, honestly, if you ask me what to do, even I don't know what to do, but what I'll present to you is what is known in such conditions, where the known genetic defects lie. So as I said, that these are normal semen parameters, no anatomical or morphological defects. Most of your hormones are in the normal range. You're taken history. There is no striking history. And essentially, they will either present as infertility, and in ART clinics, they'll present as ART failures. Often the embryologist will say there is failed fertilization. I don't get enough fertilization. The embryos are forming, but they are resting at early cleavage divisions. They are resting at 4-cell, 8-cell stages, or they are developing up to blastocyst stage, poor blastocyst quality, or typically they'll have recurrent implantation failure. Remember, unexplained male infertility could also be a cause of recurrent pregnancy losses. In the last slide, I will show you some data of how recurrent pregnancy losses, loss of 2 or more pregnancies, are actually because of a problem in the male partner, and there's nothing wrong with the females. Now, I must say that this is a black hole. Whatever sorts of investigations you do, most of them turn out to be normal because we don't know what sort of investigations we even need to do. Unfortunately, it's poorly understood. It is least investigated. It's a condition of theories, what I call, in a condition of endless investigations. The couples just keep on getting themselves investigated, go clinic hopping, go doctor hopping, and keep doing it. And it is a female who continues to suffer, and she undergoes a lot of obscure investigations and empirical treatments where the problem could most likely lie from the male partner. And this is where the WHO problem starts, that the male is labeled normal as soon as the semen count and semen motility turns out to be normal, and he's not investigated. And I'll tell you why that's a problem. So there are several factors which are implicated in unexplained male infertility. And as Dr. Sujata said, that take history. And why this history is important is our data has shown that unconsummated marriage, UCM, is about 3 to 4% in the Indian context. A good proportion of couples, even after years of marriage, have not consummated the marriage. And this is a big problem. Then there'll be problems of premature ejaculation and orgasmic ejaculation, delayed ejaculation. Now, these all things will come out when you're taking history. So please take your history in a reasonable way. Varicocele is about 25% is what I'm saying. But many of these are, upon physical examinations you get. There are many of these which you will not get upon physical examination. And one of them is the sexual dysfunction part. So please take the sexual history very well. And only after sexual history, you can label a couple as unexplained. Now, when we talk about oocyte, we are told that the egg gives all of the goodies. The woman has to give all the goodies. She'll give the chromosome, she will give the cytoplasmic contents, she'll give the organelles, and she'll give the RNA in the protein. And it is the egg which is the important thing. And the role of the man is just like a ICSI pipette, deliver the sperm. Once the sperm is delivered, your business is done. You don't have to worry about it. So therefore, the man is least investigated. But this is not true, because if the sperm apparently with a good count and good motility cannot be defined as healthy, there are a lot of unhealthy sperm. And this is very, very important because the sperm genome, the sperm genetics are getting increasingly modified. Our dietary patterns have changed with aging, with exposure to endocrine disruptors. There are a lot of changes which is happening in the testis and of course the testicular genome. Now the problem is that such abnormal testicular genomes will affect embryonic development, it will affect fetal growth, and even if these babies grow and become, the offsprings will not be healthy. And now we get into a very, very vicious circle. The problem being that unlike the oocytes, which are, arrested in the early fetal stage and the DNA damage is not very great happening there, man is continuously getting exposed to a lot of these organic pesticides, a lot of dietary factors, lifestyle factors, and his sperm genome, each cycle is getting constantly modified, and more exposures, more abnormal sperm, and more of these vicious circles. So the problem being that this leads to something what we call it as transgenerational or intergenerational programming. It turns out now that the man is exposed to endocrine disruptors, and if he conceives, there is a very strong likelihood that the babies born out of them will have diabetes, will have cardiac conditions. So if I'm suffering from diabetes and cardiac conditions, which is apparently non-familial in nature, in most likelihood it is that my father was exposed to something which was absolutely problematic, caused a problem in his genomes, and this led to unhealthy offsprings. So please remember that understanding the unexplained male infertility becomes very crucial. Now, today, up to date, what we have understood are where are the problems that contribute, the father contributes to embryonic development. This is where I'm going to restrict my talk to. That we know that sperm-derived PLC zeta is crucial, centrioles are crucial, sperm-derived mitochondria is crucial, sperm-derived DNA and epigenome is crucial. Now let's talk about PLC zeta. Now this is an enzyme which is required for egg activation. So when the ovulation has happened naturally or in the lab dish, when when the sperm goes and binds there, an enzyme called as PLC zeta is produced, which is produced by the sperm, has to get into the egg and start a cascade of biochemical events, which will lead to the first calcium wave in the sperm, and this leads to egg activation. Now it turns out that the oocyte does not have any PLC zeta. The PLC zeta comes only and only comes from the sperm, and this is required for the early calcium oscillations to prevent polyspermy, to resume and complete oocyte meiosis, to selectively recruit and degrade maternal mRNAs which are not wanted, and it is required for the first pronuclear development. And it is found that in many partners of unexplained infertile couples, there is low or absent PLC zeta. PLC zeta is functionally compromised in cases of couples with recurrent implantation failure. Mutations in human PLC zeta is reported in men with fertilization failure. And absence of this protein in sperm is sufficient to prevent oocyte activation and hence fail fertilization. So here the solution is chemical ag activation. So if you find a couple who is unexplained, in all likelihood it is possible that they're not able to fertilize because fertilization happens, the sperm count is normal, the motility is normal, so it goes up to the egg, but fertilization happens because the egg doesn't realize there's sperm there in the vicinity, and therefore it doesn't activate, and that it looks like fertilization failure. It can look like fertilization failure even in an IVF setup, and in this case a chemical activation of the egg is the solution. Next is centrioles, a very, very important organelle derived from the sperm. This is one organelle which we have completely ignored in all these years. Remember, centrioles is one organelle which is made up of many, many proteins. And this centriole is essential for all somatic cell division. So all our mitosis which happens in all the cells of our body, the two chromosomes which have to separate into two daughter cells is because of the centrioles. Centrioles form like anchors there, which allows these threads of chromosomes to get into two different things. Now remember, the egg does not have any centrioles. The centrioles are coming from the father. The sperm is giving the centrioles, and it is used now for your first cleavage division. So if your pronuclei have to come together first and do the pronuclear fusion, and then the first division has to occur and the two nuclei have to get into it. This is all through the contribution of the paternal centrioles. Remember, the mother is not going to give the centrioles. And any defect in the centriolar proteins will manifest as unexplained infertility. What we now know currently is that mutations in some of the centriolar proteins can cause fertilization failure even after ICSI, because you now give the centrioles are now, you give the nucleus, but the nucleus is unable to go to the female pronucleus, it's unable to fuse and it's unable to separate, is because the centrioles are not healthy or centrioles are completely missing. And this is an example here where there was a mutation in one gene called as SPATCTL, and in this man there was consistently, there were embryos which were arrested at 1 cell stage, or at 2 cell stage, or they were degrading very rapidly even after the divisions have occurred. This is all because of mutations in centriolar genes. So, and the sperm centriole, so there will be a subset of unexplained infertility, and centriolar mutations are not going, some centriolar mutations can cause MMF, but many centriolar mutations is going to result in a normal sperm count and normal sperm motility, but it is going to be a problem. Now, some of these centriolar defects can even lead to aneuploidy in the embryo. So as I told you that it's required for separating the chromosomes, some of the centriolar proteins are there, they're allowing some amount of cell division to happen, but the distribution of the chromosomes was so abnormal that you will get chaotic embryos with a lot of problems in their chromosomal complement. And men with low centrosomal proteins, in many men with oligozoospermia, even unexplained oligozoospermia or even normozoospermia, men with low centrins have low pregnancy rates. So if you measure the central levels in the sperm, it turns out, this is one study done at our institute in collaboration with Dr. Indira Hinduja, and it was reported by them that the numbers of men with low centrin levels, the pregnancy rates are significantly lower as compared to the men with high centrin levels. And there was a recent study which was published in JARG which showed that men with low centrin levels have high rates of embryonic aneuploidy. So remember that your centrosomal proteins are crucial, and that could be a problem there. Moving to sperm DNA. Sperm DNA, as you understand, it's most important part. And if there's any problem with the sperm DNA, your embryonic development can be compromised. Now, this sperm DNA defects can be classified into 4 categories. One is Y chromosome microdeletions. Now, this will not manifest as unexplained male infertility. It will be idiopathic male infertility because it will manifest as azoospermia or oligospermia. But in men with unexplained male factor infertility, normal sperm counts, you can have sperm epigenetic modifications or DNA fragmentations. Let's look at DNA fragmentation. Very, very popular today. DNA fragmentation test is now being consistently offered in a lot of clinics. And we know that men with high sperm DNA fragmentation rates have low clinical pregnancy rates and low live birth rates. This has been proven across various studies, and this is very important test which can rule out that, okay, now you have a normospermia, but you have, if you have a high DFI, then it could be a cause of fertilization failure. It could be cause of poor embryonic development and hence failure of pregnancy. Now, this sperm DNA damage can cause because of various conditions, as I said, environmental disruptions, endocrine disruptors, hormonal deficiencies, varicoceles, protamine deficiencies, occupational exposures like exposure to solvents, metal industries. So therefore, it is important to take history that if the father is working in any of these or has some of the recreational issues like cigarette smoking, alcohol exposures, taking recreational drugs, STI, RTIs, infections, or genetic mutations, all of these can cause sperm DNA damage. And in almost all of these, remember, oxidative stress is the underlying cause of sperm DNA damage. For reasons, by various mechanisms, which I'm not going to get into, all of these kinds of conditions, especially environmental, occupational, and lifestyle, and advanced paternal age, increase in oxidative stress, and therefore it will cause sperm DNA damage. And in these conditions, your antioxidant therapies will work. Remember, your antioxidant therapies will not work when there are genetic mutations, there are CBAVD, there is Robertsonian translocation, there is Y chromosome microdeletion. If there's oligospermic man with all of these problems, they're not going to be helpful with antioxidant therapies. But if it's a normospermia, antioxidant therapies may work there. So to decide whether to give a man an antioxidant therapy or not will depend on your DFI status. Only if the DFI is a problem that antioxidant therapies may work. And if the DFI is a problem, only because of a lifestyle or environmental factor, not because of a genetic factor. So now you understand why it is important to rule out between these conditions. Moving to epigenetic modification, slightly complex to understand. I'll try to make it simple. Remember, your genome is like your system which is going to make the proteins. Now, how do the DNA know that how much of protein to make? One of the mechanisms it is to do is something what we call it as DNA methylation. If the DNA is methylated, a zip is put on the DNA, it will never make that protein. And if the DNA is getting demethylated, the protein will get expressed. Similarly, there are modifications which we call it as histone modifications because of HDACs and HATs. And these two together control which genes will be made, which genes will not be made. Just to make it simple, that my eyes has to make proteins which are required for photoreceptors. My brain has to make proteins which are required for neurons. You don't want photoreceptors and brain proteins to come in the testis or to come on the skin. Why? How this happens? It happens because of these epigenetic modifications. I must remind you that a lot of epigenetic modifications are causes of cancer, and a lot of these epigenetic modifications can be caused because of environmental defects, like environmental cues, pesticide exposure, heavy metal exposure, phthalates. All of these can cause epigenetic modifications, and lifestyle modifications like and these can be improved by lifestyle modifications like by supplementing with micronutrients, phytochemicals, vitamins, controlling your dietary intake. So many of these epigenetic modifications are reversible and can be taken care of. So there are a lot of studies which have shown that in infertile men have almost 10-fold increased risk of an aberrant DNA methylation in their sperm, indicating that, so this is a study which was done where they'd taken all men with semen abnormalities. I'm talking of the category 1, the control men with normal parameters, and as compared to normospermic men who had some babies, the infertile men had completely abnormal semen profiles with DNA methylation, indicating that DNA methylation could also be a problem leading to oligospermia. But now the problem doesn't stop there. Our problem starts where you have a couple who is coming with unexplained infertility or recurrent pregnancy losses. 2 studies published in quick succession from our institute, I'll close with this, where they have shown that the amount of DNA methylation in the sperm of male partners with recurrent pregnancy losses is significantly lower. You can see here it's about significant, about 25% of the DNA is less methylated, telling that there are a lot of unwanted genes which are being expressed. Remember, this packaging is very crucial, and if not packaged correctly, the sperm will not function correctly, and the embryonic development will get compromised, or the mutations or the embryonic development will be compromised. The embryos may appear healthy and implant, but it will abort because of these epigenetic modifications. And this is one example where they've shown in a locus called as IgTMR or IGF2, which is required for growth of the baby, there is some level of hypomethylation indicating that there is a problem. Dr. Dipti Singh from our institute said that, okay, I'm not going to look at 1 or 2 locus, I'm going to look at all the possible genes where there is abnormal methylation. And you can see that nearly 50% of the genomes have problems with methylation. Either there's too much of closing of the genomes, or there are several regions which are too much open as compared to normal men. These are all men with recurrent pregnancy losses. So it turns out that it is not just infertility which is manifested as a problem with the father. A lot of recurrent pregnancy losses also could be with the problem with the father. So just to summarize, I know it was too complex and too much to grasp in this short of time. I'll quickly summarize that your undetermined male infertility, which I now like to call it that way, could be classified as idiopathic male infertility or unexplained male infertility. Idiopathic male infertility, obviously the semen analysis is a problem, and these are largely because of genetic defects. Unexplained male infertility could be because of internal problems in the sperm, either at the level of DNA, as Sujata ma'am said, it could be level at the problem of RNA, like DNA fragmentation, abnormal methylations, abnormal epigenetic changes, increased reactive oxygen species, and activation factors like PLC zeta. These can have a completely different representation, from classical infertility to recurrent implantation failures, to recurrent pregnancy losses, to fertilization failures, to embryonic arrest. So now we are dealing with a problem, and it is important that we identify what is the final problem that's coming in this infertile couple, so that your management modalities can be appropriately given. So the way forward, as Madam said, number one, we need to define what we would want to call properly in the Indian context again as unexplained infertility, because these definitions can vary across the globe. So as India, I would suggest that ICOG takes notion of this and starts defining what should we call it as unexplained infertility. You are experienced people, and experienced people must voice out that what is it that we want to call it as unexplained infertility. We need not go by the Western definitions, number one. Number two, we need to need more research to identify the causes of unexplained male infertility to be unraveled. And this will only allow people like us to develop toolkits. Now, at the end of the talk, if you ask me that, how will I know that there is a problem in my patient with DNA methylation? Or how will I know there's a PLC zeta defect? Or how will I know, how can I identify this defect? Except for the test of DFI, no tests are commercially available. None of these tests are even validated or benchmarked. All of these findings, which I told you, only come from research labs with a very, very difficult to do test, not typically applicable in clinical setup, but only when the clinicians start demanding this, that people will like us will start developing them. So we need to develop these toolkits. And once we identify the problems, that will be able to define management modalities and treatment modalities. And I'll close saying that only when we do all this, that we will properly move to personalized medicine, because male factor infertility is not one problem. It is a multitude, it's a bag of problems. And all of these cannot be treated with a single condition. It will need multiple conditions. And with this, I'll close and I'll be happy to take questions. Thank you so much. I'm sorry, I think I've exceeded some time.
Thank you very much, Deepa. It
Thank
is
you.
always a pleasure listening to you. I think you always bring messages from the bench to the bed. I think I always find that you connect to the clinician so very beautifully. So very beautifully. You talk a complex thing and then you bring it so close down and then you bring to our patient care. That's one of the beauty of your talks. And we truly appreciate you coming here and then, giving this talk. And it's such a less explored and less investigated problems of infertility. I think Deepak will take the questions at the end. We will move on to the next talk. The next talk is by Dr. Nirmala. She's talking on counseling for further management. How important is it? So Nirmala, a good friend of mine, she is an diplomat of National Board, and she also has a diploma in reproductive medicine from endoscopy and sexual and reproductive medicine. She's a very popular and a well-known practitioner in Bangalore, and she believes in individualizing the patient protocol and to get the good results. And she has been the most sought after speaker, at least in state and national level, I know for sure. She's a popular performer in various television channels, and she has got several, she has written several articles, and she has also been awarded the Karunada Siri Award and Aryabhatta Award. And her Karnataka's first test tube baby center, her center was the first one to give the vitrification baby. And this is about Dr. Nirmala. Nirmala, we look forward to hear from you.
To Dr. and Dr. Madhuri for the wonderful opportunity. I'm just trying to share the screen. I don't know what is going wrong.
I think your internet connection also is not okay. I mean, your voice is breaking.
Yeah, Nirmala, you're frozen. I think there's some internet issue.
I think you log out and log in again.
Madhuri, can we take one or two questions till she logs off? And
Yeah.
Rita, can you see any questions in the chat box?
No, there are no questions.
Okay. I have a question for Dr. Deepak Modi. Dr. Deepak, in the evaluation of male infertility, apart from sperm DNA fragmentation, what are the tests that are available in the market which can be done?
So unfortunately, most tests which are available are restricted to the man who have abnormal semen parameters. So there you would definitely start with a karyotyping followed by a Y chromosome microdeletion testing, two basic tests. If it is azoospermia obstructive, then you would straight move to CFTR testing. Now, these are the only ones currently available. Of course, then you have some sperm function tests. Classically, WHO used to recommend a bunch of sperm function tests, but like HOS and so on and so forth. These gave a lot of leads to researchers like us that where the problem could be. But because clinically they were really irrelevant and we could not make any sense of the results, slowly they've disappeared from the market. Like, for example, sperm viability test. We really don't do in the clinics today, but I think some of them needs to be done because, you know, if a man is producing non-viable sperm, implies there could be most likely oxidative stress or infection, and then your treatment modalities will change. So I think some of them which we know already could be infection panels which we could do, but apart from that, I don't think there are any ready to go tests as yet available.
Zeta and all that, any new test which has come into the market, like which can be done? Sperm PLC, Zeta usage.
No, these are not available in the market. Most of these are only restricted to research labs.
Just a quick question, can I ask Deepak?
Sure.
You said 80% of them with obstructive azoospermia have CFTR gene mutation. Is it specifically obstructive azoospermia with absence of VAS? Because obstructive azoospermia can be due to problem at different levels also. This 80% is a very big percentage. I was surprised.
Yes. So this was a study again done by Rahul at our institute, and definitely he did show that if you take a group of obstructive azoospermia with congenital bilateral absence of vas deferens, no kidney involvement, almost 100%, 95% will have CFTR gene mutations. But if there is a kidney involvement, then the mutation panel changes, but there is again a genetic involvement. So I think I've answered your question, right?
Just one basic question to you, Dr.
Sure, ma'am. Sure, ma'am.
When we clinicians should refer the patient for genetic counseling?
Good question. I'm glad this has come up. So first primary evaluation you do, and I would suggest that as a part of your primary evaluation, do a karyotype and Y chromosome microdeletion testing if there is a semen abnormality. So I'm talking of the male partner. And as soon as that is available, you need to send it for a genetic counseling. Now, unfortunate part here is that number one, we have very few genetic counselors in this country. And most of these genetic counselors are unfortunately not trained to counsel infertile couples. They can either counsel the preconception couples or they'll counsel the, the pregnant couples. And unfortunately, we realize now that the infertility genetic counseling is completely a different ballgame. So what you will need to do is to send it to somebody who is sensitive to infertility counseling and also knows some bunch of genetics.
Do you know somebody who is providing them online? Because I am from Nagpur, and Nagpur, as you said, we have many genetic counselors who are doing this prenatal and pregnancy counseling, but not infertility counseling.
Yes. So as the convener of IFS SIG Special Interest Group in Applied Genetics, we are trying to gather this pool of genetic counselors who are willing to do infertility genetic counseling. We'll need some time to do it, but I think by the end of in next few months, I should be able to come up with that list. I'll take that on priority basis now.
Yeah, because I mean, our couples, they do need these kind of services, and we as a clinician, we just can't handle them beyond a certain point.
Absolutely. But that's why, that's why I was developing these algorithms that at least you know what to do. That, okay, there's an infertile man with a karyotype defect. Often at the level of clinicians, you don't know what next to do. Now, so I've published these algorithms. I'll try to send these chapters also to all of you. So you can use these algorithms, at least basic level of counseling you can do. That, acha, karyotype defect hai, Y chromosome hai, to ye problems aapko aa sakte hain, and this is what the options available for you. At least at basic level, I would suggest has to be done at clinics, because honestly, we have too few counselors in this country. So we'll empower you as well. So we'll come up with IFS. We'll try to come up with these algorithms as well to make your life easier.
Thank you. Thank you so much.
Deepak, this genetic exome sequencing you said, do we need to know what is the genes we are looking at? Is there any genes identified, known genes? Like, if there's an unexplained infertility, these are the genes which we look for the mutation in these genes. Is it there like that, or we just, what is the genes which you are looking at?
Yeah, so the good part here is that the exome sequencing allows you to look at all the possible genes in the genome. So you don't have to worry. But that means, when you're looking at all the possible genes, and you also have a problem of misidentifying something, which is, may not be really very relevant. So the panel of genes which were so commonly reoccurring in infertile couples, it will be available soon in the market. People are developing it. Probably even for the Indian population, we will be having that panel absolutely ready. So in time to come, you will have these tests. As of currently, some of them, like for example, MMF, we know very clearly what genes to look at. Obstructive azoospermia, we know which genes to look at.
I think Nirmala joined.
Okay.
Just check.
Is she there?
Yeah, I think she's there.
Nirmala, can you please take over?
Should we call her?
I'm here. Can we get on with the next speaker in the meantime? I'm trying to.
Okay. Oh, so I think we can take questions for Sujata. Rita?
Questions for Sujata? In the chat box, I didn't see questions. Can people ask directly? Raise the hand and can people raise their hand and ask question? Because I don't see anything in the chat box.
I think Nirmala is sharing her slides.
Can you see my slide?
No, Nirmala, you open your slides on your this thing and then share it.
Your voice is very clear now. Probably you need to share your screen.
1 minute. Now, can you see the?
Yeah.
Okay.
Just go to slideshow.
So you can hear me also?
Yeah.
Yeah, we can hear you.
All right. So good evening, everybody. And I'm absolutely apologize for this shortfall. So it was a wonderful session by Dr. Deepak and Dr. Sujata earlier. Thanks, Dr. Madhuri and Dr. Rita, for those wonderful words. So the topic that has been assigned to me today is how do we counsel for further management in these cases? The aims of counseling, as all of us are aware, first we need to actually explore, understand what is the primary cause and clarify what are the different ways of resolving this problem and in a most effective and a sound evidence-based practice. That is the primary thing that we need to understand. So, and also never to forget that we must involve all the patients before we make any decisions on the treatment choices. Now, to understand, as the previous speakers did mention, unexplained infertility itself is actually a diagnosis of exclusion. Have we arrived at a right direction? There are so many definitions, so many things, and so many confusions around this terminology. Primarily, we should throw questions like, has the couple undergone all the standard investigations for infertility, like the ovulation induction test, and then the semen analysis, and the tubal patency test? And was these tests done correctly? And above all, have they been interpreted correctly? Which is very, very important. And one must remember before we counsel a patient, what is going to be the next move? We have to understand that many a times there are a lot of underlying conditions which have got missed out, like the endometriosis, subtle tubal pathology, because many a times the hysterosalpingogram report has just been evaluated as patent tubes. But are we looking at the architecture, the morphology of the tubes, whether they are clumped, the fimbrial ends, lot of other subtle defects? No, we do not. So these things need to be understood. Premature ovarian aging and not to be forgotten, especially in our own Indian scenario, because our Indian women seem to be aging 6.5 years ahead of the other ethnic races. Immunological infertility. So these conditions get misdiagnosed many a times as unexplained. And they could actually contribute to the treatment failure. So we need to rule out these before we go ahead and counsel the couple what next. And when we speak to the couple, we have to make them aware that the natural fecundity, which is a chance of a clinical pregnancy in one menstrual cycle, which normally is around 20% in a young couple, but in this category of women, it is generally less than normal. So the further management actually depends on how old is the woman, what has been the duration of infertility, and then balance these aspects against the management, viewing or weighing the efficacy with the costs and the side effects. So we generally tend to take these three parameters into our consideration before we strategize what is going to be the future move, out of which the maternal age is the most important prognostic factor, duration of unexplained, and then of course, whether she's a primary infertility or a secondary infertility. So how do we strategize them? Somebody who's less good prognosis, less than 35 years, and the duration of unexplained is less than 2 years, yes, you could still attempt giving her expectant management, but somebody with a little longer duration, about 2 years, active management is required. Age about 35 to 39, we do not want to wait for longer years. Only 1 year is considered as a duration of unexplained. Above 40, there is no wait and watch policy at all. We need to counsel them to move actively into management. There has been a lot of methods recommended. Many of them are empirical, expectant management, ovulation induction with the oral anti-estrogens or the gonadotrophins, and fallopian tube, sperm perfusion, tubal flushing, etc. do not stand the test of time. Intrauterine insemination with ovarian stimulation, and lastly, the program of ART. So who is the patient we are going to suggest expectant or even talk about it in our counseling is very important. We need to counsel them adequately, what in the sense, give her the actual facts of when we are opting for expected management, what is the average cycle fecundity we are looking for in her, and allay all her fears, because this particular modality has a very limited role to play. Maybe only 6 to 12 months you could advise them. And that also, a patient selection criteria is important. Somebody who's less than 25 years and less than 2 years of duration, maybe that is the group. There's only one study which showed less than 3 years of duration and less than 25 years, the pregnancy rate is very good with expectant management. But also to remember, after the age crosses 30 years, the pregnancy rate is 10% for each year afterwards. Unfortunately, this is something which you actually cannot predict. So which couple is going to conceive spontaneously and in what time frame is something which is unknown. So when we advocate or counsel them that we are going to just adopt a watch and wait policy, we have to be very careful. The disadvantage is it is not very practical in all societies, especially where the social expectations are quite high, and in older women, not to mention. Right, there are different drugs. So what is it that we are going to speak about next? What kind of protocol? What is the cost involved in the protocol is something which we need to discuss. And there are different protocols starting from the lower modalities like the oral antiestrogens, clomiphene, anastrozole, which is the aromatase inhibitors, before we move on to the more and more higher drug protocols of gonadotrophins. But it's important to make them understand that whilst we are talking about a time frame, that these oral antiestrogens, given the evidence from ASRM practice committee, the Cochrane reviews, clearly points that there has been no great benefit. It is as good as an expectant management. Same applies to the aromatase inhibitors. Coming to the gonadotrophins, yes, there is an increase in pregnancy rate when compared to the oral antiestrogens. Now, when you combine these ovulation induction agents with intrauterine insemination, and the rationale to be explained to the patient would be, why are we wanting to do this? To hasten the whole process, because you're increasing the sperm density, bringing them to close proximity to the tubes, and that is where the egg is released and waiting. So this is the reason why one would want to combine IUI in these patients. This can be done in natural cycle or with the use of oral antiestrogens or with gonadotrophins, but evidence is very clear that a stimulated cycle IUI is any day better than the natural cycle IUI or the oral antiestrogens. This is what the evidence also states, that expectant management is just about comparable to oral antiestrogens and timed sexual activity. Among the oral antiestrogens, clomiphene is better than letrozole. Gonadotrophin any day is more effective in these couples, in these patients, and gonadotrophins, if combined with IUI, is as effective as an ART program, and it can also accelerate time to pregnancy. The RBM Journal 2022 also supports this view that the first line treatment can be expectant management or ovulation induction combined with or without IUI or IVF. And they say that live births are better with IUI and ovulation induction, and especially when you use low dose gonadotrophins versus IVF. And they have also reported the well-designed studies that 3 cycles of gonadotrophin and IUI is equivalent to 1 IVF. So why would we want to then move them into the IVF? Yes, the decision could be made here if the woman is elderly, about 35, or if there's a long-standing duration of infertility, or if there is a need to hasten the time to pregnancy. So these are some of the evidences from the Cochrane library 2019. We don't find any great evidences coming across from most of these. So the indications for IVF FOGSI becomes a woman greater than 35, duration of unexplained infertility greater than 2 years, or she has already tried 3 or 4 failed cycles of intrauterine insemination. So this is a better way of counseling, that we try to move the patient based on her age and the duration of infertility from the lower modalities to the higher modalities. So IVF any day offers the highest success if you see this bar chart, that across all age groups. And this is what ASRM, as well as the recent Cochrane review, states, that IVF offers better success. Again, if you look at Canadian society guidelines, there is a very good level 1A evidence which says that the good prognosis patient expected management can be offered, but natural cycle not to be offered. Clomiphene has no benefit, aromatase has no benefit. IUI with the oral agents can be more effective than expectant, but with gonadotropin definitely increases the live birth rate per cycle. But not to forget that it is also associated with the increase in multiple pregnancy. So with all judicious, all caution, we should be using it. Then, so the very recent practice committee, ASRM, has also some similar conclusions made. It says that there is good evidence which does not support IVF as a first line over an expected management in a younger woman. Good evidence that immediate IVF is a much better way to move if the woman is above 38 years. There is good evidence to say if she has already failed 3 to 4 cycles of IUI with clomiphene, let us not wait by giving her more and more IUI cycles, now moving with gonadotropins. Instead, IVF becomes a better option even if the woman has a good prognosis lesser than 35 years, is what the ASRM practice committee says. There is good evidence to say there is no difference in the clinical pregnancy or the live birth between IVF FOGSI. The only advantage of giving an option of ICSI is to avoid a total failure and to increase the fertilization rate in these patients. Again, this is the Unexplained Infertility Guideline Group 2022 draft, which is again very similar to what we just saw. IUI with ovarian stimulation is the recommended first-line treatment for couples with unexplained, and a strongly recommended one. ICSI is not recommended over conventional. If you look at the oral anti-estrogens, again, it goes more in favor of IUI combining the ovarian stimulation with the gonadotropins. Not to forget the higher incidence of multiple pregnancy, and accordingly adopt a low dose regimen. IVF is probably recommended over expectant management in couples with unexplained, which is only a conditional note. So it is expected that the decision to use IVF has to be individualized based on the patient characteristics. Especially here, I would like to counsel and factor the age of the woman and the duration of infertility. I have been repeatedly stressing on these two factors because eventually I think it is important when we are talking to the patient, who is it that we are talking to and counseling. Now, is there a role for adjuvants? Because today, many of these patients, when they come to us, they come with a whole load of prescription of all these adjuvants. Very clearly, none of them have any role to play. Psychological support, yes. Psychotherapy is recommended for patients. Now, as far as the quality of life, it is clearly stated that there is no difference in the quality of life between a woman with unexplained infertility as against a woman with other causes of infertility. Only exception here is a woman with PCO who expresses a low quality of life. So to conclude, the salient features of counseling with all the available evidence, counseling on further treatment, in my view, should be in this direction, mainly considering the woman's age and the duration of unexplained, adverse events, and the cost effectiveness of the different modalities should be evaluated before concluding. We must make it a point to rule out all the misdiagnosed underlying conditions first, because as Dr. Deepak pointed. Now, if you start looking at higher and higher investigations, you will see that more and more the diagnosis and the definition of unexplained gets narrowed down, may not even exist. But the more shallower the investigations are done, it is more widely diagnosed as unexplained. So this is where we stand as far as unexplained. Younger women adopt a stepwise treatment starting from the expectant management, followed by ovulation induction and IUI. And if this fails, then adopt IVF by ICSI. Not to forget again that Indian women's ovary age is 6.5 years ahead of other ethnicities. So here we are racing with time, and we should take it's a time to clinical pregnancy, especially in duration of unexplained infertility. And we must remember that the pregnancy decreases every year after 40 years, and IVF becomes a choiceless choice at that age. So that brings me to the end of the session. Thanks for the patient hearing.
Thank you, Dr. Nirmala, for a beautiful talk. Yeah.
Thank you so much.
Yeah. Now, obviously, the management in general depends upon age. It boils down to management is based on age and egg reserve. If she's in the older age bracket and the reserve is not really good, there's no dilemma in our mind at all. Though she has been branded as unexplained, you know that it's probably because of low reserve. In the younger age group with reasonably good reserve, we have the option of going for IUI or IVF again. Very beautifully she covered saying that IUIs with gonadotropins definitely have higher success rates, but then we might end up having a higher incidence of multiple pregnancy that requires a lot of counseling. And if we go on doing too many cycles of IUI with the gonadotropins, the cost is not going to be much less compared to IVF. Again, that boils down to counseling. We need to offer the couple saying that I can do IUI few cycles with gonadotropin injections, but then you may have to go on spending a lot of money. It depends upon the availability of the. And obviously, IVF, because we take out several eggs, then the probability of getting a good embryo is higher compared to IUI. IVF gives better success rates. Thank you all very much on behalf of Shobna and myself. I'd like to thank Madhuri and Lakshmi for giving this opportunity. A lot of learning happened, especially Deepak's talk was wonderful because that's why IUI doesn't work. We go on doing IUI processing, look at only motility, and we have the original morphology report, and we think that the post-wash count is good, but then the centrin levels and DFI and so many things we talked about. Nice, it was a good understanding. We have so many points to counsel, the couple.
He is waiting to comment. Yes, Dr. Deepak.
Yeah, I wanted to have a comment for Dr. Nirmala that that's for everyone in general, that we talk about that Indian women typically tend to age earlier. The age of menopause is much earlier. And we still keep on defining age of 38 as our cutoffs to give them a lot of these options. Isn't it time that as Indians, we redefine our needs, our women's needs? And what are the points that we should start from? How should we go ahead saying that no, in India, probably 38 or 35 is not the right cutoff. By the time the woman is nearly almost gone into menopause, most of our women. So how do we do it? And let's begin discussions this
I think 34 should be the cutoff for the Indian woman instead of 38. There are some which even consider above 32 as...
perimenopause is 12 years before that. Menopause 12 years before, so you have to consider it 10 or 12 years before 38 or 36, whatever is your cutoff. So I think it has to be, you find premature ovarian insufficiency in 28 and 29 also these days.
Can I say something? Can I say something?
People, they wouldn't have completed the studies and they wouldn't have started, they will laugh at us if I said 28, where the girl wouldn't have thought about marriage also. At this, where we are living, the era where we are living now, 28 or 30, nobody, if you talk to them telling that ovarian aging and all, they will, we are not in that stage as such. As you said rightly, we have to make a beginning. But I think, yeah,
But we should start talking about it, Shobna. I think we will have to change these criteria. I think, see, we were actually earlier saying 35 is elderly primi gravida. 35 was elderly primi gravida. Now, what is elderly primi gravida? 45. I mean, so therefore, our own definitions have changed. We have to go back to the earlier definitions. Women were getting married at 25. Even postgraduates got married when they were doing post-graduation in medicine. So that's what I'm saying. They may laugh at us, but we have to make them realize it. Deepak is right.
So they connect to us when we tell them that they are attaining menarche earlier. They connect because they are bringing the children, you know, they're all 5th standard, 4th standard, they're all attaining. So they are attaining menarche earlier, menopause earlier, getting married late, postponing their pregnancy. So if you bring this whole context, no, then they will understand.
They understand, yeah, of course.
Then, you know, that's where, like, I think every patient.
No, I agree with Dr. Sonia, because we looked at our own data of doing AMH on the category of patients, and we found that almost 35% of the women between 30 and 32 had a very borderline AMH. So if you are able to capture that group, which is already bordering on a low AMH, that is the group which we are actually going to help before the actually.
Absolutely.
So about 32 to 34, there were about 40-45% of people who were having an AMH less than 1. So what is important is to catch this group much before they go to less than 1. Because there's very little that we're able to do once they drop less than 1.
Absolutely, absolutely. We have to go back to the pre-Ayurvedic times when we were, you know, asked to get married at 16 and have a child at 18 and finish the family by then. It'll have to be like that. We'll come back.
I think we need to bring about
for that matter, when you're looking at the basic investigations with which has been recommended, is AMH is not included actually in that.
It's not included, yes. Yes, true.
So I would like to thank both the chairpersons, Dr. Shobna and Dr. Rita, for conducting the session so well. And we'll then go on to the next session where we have Dr. Chaitanya Shembekar, who is the president of Nagpur OBGYN Society, chairman of the Infertility Committee of AMOX, librarian of Maharashtra SR, and he's also the member of the Infertility Committee of FOGSI. He's recipient of several awards, and he also has several publications to chair the session. Our second chairperson is Dr. Parikshit Tang, who's a consultant at Ashwini Maternity and Surgical Hospital and ART Center. He's also a consultant at Jupiter Hospital, Thane, and honorary professor at the Pacific Medical College, Udaipur. He's a consultant for assisted reproduction at 16 centers. He was the treasurer of FOGSI, chairperson of the Safe Motherhood Committee, postgraduate teacher and examiner for CPS and examiner for MRCOG, and he has several awards to his credit. So we would now go on to the second session. Chaitanya, you can introduce our first speaker, Dr. Sonia Malik. I'm not sure if
Chaitanya and Parikshit, I think Madhuri.
Yeah, I'll do it. Yeah. So we have none other than Dr. Sonia Malik, and she gave me a lot of galis because I gave her this topic.
Thank you for admitting it at least.
So she's been the past president of the Indian Fertility Society, chair of the Infertility Committee of FOGSI, and past president of the Indian Menopause Society. She's associate editor for several journals, and she's a member on editorial board of several journals. And she has several awards to her credit. So I think we'll have Dr. Sonia.
Thank you very much. First of all, Lakshmi, thank you for this brilliant seminar or webinar series that you've begun. I'm sure it's going to help most of us revise our medicine. And of course, you have the great person next to you, Madhuri, who is such a Hitler. She will make you do anything that she wants you to do. So thank you, Madhuri, for giving me the choicest subject to talk about today. You had given us the other bit of it, you know, to Deepak. He's a basic scientist. And here I am, a clinician, trying to struggle with the maternal contribution to unexplained infertility. So let me see how I can do justice to this, as to, what could be, what I can say about it. So anyway, what is unexplained infertility? I'm not going to repeat it again, but actually it's something that doctors can't figure out. They don't know what is happening. And basically what we are looking at is infertility in which the standard fertility testing has not found a cause for failure to get pregnant. And unexplained infertility is also referred to as idiopathic infertility. Now, if you look at the possible causes of unexplained infertility from the maternal point of view, look at this statement, which is in one of the blogs that I found out, right from the beginning, where the hormones are used to stimulate the oocyte for development. You go on to the development of the early embryo, the blastocyst, and then the endometrial lining, the H blastocyst, so many other things. So basically, right from A to Z, it's all the mother. So we are today trying to explain this unexplained, and let's see what we can do about it. But first of all, let us see what the International Grossly on Infertility and Fertility Care 2020 has to say about, 2017 has to say about the definition of unexplained infertility. This was led by the International Committee of Monitoring for Assisted Reproductive Technologies. And according to them, infertility in couples with apparently normal ovarian function, fallopian tubes, uterus, cervix, and pelvis with adequate coital frequency, and apparently normal testicular function, genitourinary anatomy, and normal ejaculate are considered as unexplained. And the potential for this diagnosis is dependent upon the methodologies used and those methodologies available. So basically, here is the catch. Here is where we can actually play upon it and see what we can do about it to make it better. And then, of course, as Dr. Nirmala mentioned a little while ago, the Practice Committee of Management, ASRM Practice Committee Management Guidelines still says that the evaluation should typically include the demonstration of at least one patent fallopian tube, documentation of ovulation of the female partner, and semen analysis with an adequate number of motile sperm. The ESHRE guidelines are still to come. The draft is ready, and that has been shown by Dr. Nirmala. We will see what changes there are in that. But as of now, we go by the standard definitions which have been given to us. And this is a beautiful slide by Madhuri. I thank you for this. If you again look at this, look at the hard work that she's done to collect the various features and the various factors which can be responsible for unexplained infertility, I would say, and what all you can actually look into. And so therefore, leave the male factor aside, because that is something that Deepak has already alluded to. But if you look at the female factors also, it's humongous. The list is unimaginable. And once you have actually looked at all of this, does it remain explained? No, I think we would have explained everything. And so we would know why the patient is not conceiving. So therefore today, to sum it up, to summarize a little bit of it, we are going to just talk about aging, luteal phase dysfunction, abnormal endometrial receptivity, poor egg and embryo quality, and of course the immune disorders. So let me see if I can do some justice to it. These are some common conditions which are not diagnosed early, and therefore they are labeled as unexplained infertility. And this is basically something that we all know. Mild endometriosis can be missed, subtle tubal pathology can be missed, premature ovarian aging has been alluded to a lot. Age-related infertility, I shall talk about immunological infertility as well, and not sperm dysfunction, but oocyte and egg quality. So what about mild endometriosis? We know many a time when patients come to us, we are not straight away taking them up for laparoscopy, and therefore we go on doing ovulation induction, and we keep on doing IUIs, and we find that the patient is not conceiving, and finally we suggested laparoscopy to them. And then we find that the patient is riddled with endometriotic lesions, so we have missed that mild endometriosis, and that may be the reason why she is not conceiving. This can also be associated with an abnormal tubal function, abnormal ovarian function as well, fewer eggs at the time of retrieval, low egg quality, and of course a lowered implantation and pregnancy rate. They may release toxic substances. We all know that endometriosis is known for that, which may harm the embryos and also affect the implantation potential. So essentially, endometriosis is something that is readily missed in our infertility practices. Subtle tubal disease also is something that Sujata had alluded to, and she said that, when you do a laparoscopy, you find that the configuration of the tube and the ovaries is distorted, and therefore the patient is not conceiving. So this cannot be identified with traditional tests and which we have for tubal patency. For instance, HSG is not going to tell you how the tube is placed and how the ovary and ovarian ligaments are placed. It is inadequate in assessing the tubal disease, basically as a first-line tool. And of course, reliable interpretation of HCG suffers from considerable variability also in interpretation and also in the conduct of the HSG. You may find a report from a very good radiology lab, but at the same time, radiology labs in the far interior may not be as sophisticated as you have. They may not have fluoroscopy, and you may be having these HSGs which are not up to the mark. So again, we must remember that the tube may not be functioning properly, even if it is patent. Many times I tell the patient that, your tube is patent, but then you are not getting pregnant because maybe the secretion that the tube is supposed to give out, or the fluid in which the embryo actually bathes and takes its nutrition in the first 6 days of its life, is not normal. And we have no way of proving whether it is normal or not. So therefore, a patent tube is not essentially, does not essentially mean that this tube is functionally also correct. So therefore, we also have to understand that the motility of this tube may not be proper, which may also be the reason why this is not happening. Now, coming to the first part of what I was supposed to talk about, aging and unexplained infertility. So, since fecundity, we know, declines with age, it becomes very difficult to disassociate unexplained infertility and age-related infertility as she is aging. There are rates of false positive diagnosis of unexplained infertility because after the age of 35, they seem to be merging together, as we were discussing just now. The threshold of 2 years of unfruitful, regular, unprotected intercourse rate exceeds 50% in women starting to seek a pregnancy after 37 years and 80% after 40 years. So basically, this is why we were just now saying that we may have to redefine our own age limits in this country. And of course, ART is unable to overcome age-related infertility in older women, erroneously labeled with unexplained infertility, which may receive inappropriate therapies. So yes, this is extremely common that we have these patients who are being subjected to repeated ovulation inductions and repeated IUIs before they are even referred to a consultant for IVF. So this is associated with a change in fertilization and implantation potential of oocytes and embryos. There is an increased risk of embryonic chromosomal abnormalities and of course, an increased risk of spontaneous abortions also. So hence we have to consider that any patient who is aging is not necessarily unexplained. It is explainable because of her age. We know that the ovarian pool diminishes. At birth, the ovaries contain about 1 to 2 million eggs, which again start decreasing as the child reaches puberty to about 35,000 to 500 eggs in the ovary. And then as she reaches menopause, the ovarian reserve goes down to 0. And hence the optimal fertility gradually declines to the end of fertility, which is of course in India, earlier than the rest of the world, somewhere here, whereas in the others, we may have patients coming from the United States telling us there the consultants have told us that you can conceive even at age 42 and 43, and then we don't know how to counter that because we know that our own fertility demographics are very different. Fertility rates, as we all know, that they start declining from 20 onwards, with 24 being typically quoted as the peak fertility age. The egg pool is abundant and most of the eggs do not have chromosomal abnormalities. So therefore, there is a very high chance of conception. And before the age of 30, 25% will have a chance of getting pregnant in a menstrual cycle. And about 96% of those younger than 25 and 86 of those approaching 30 will get pregnant within a year of their trying. Miscarriages rates are also low to the tune of about 10%. Hence, you have to counsel your patient to get pregnant faster. As the age advances to 35 and above, there is a decline in the ovarian rate. There is acceleration of the rate of the decline. And of course, the DNA and more abnormalities keep on happening. These can complicate the fertilization of the egg, and of course, pregnancy rates decline. So at this age, 15% can get pregnant, and the risk of miscarriage increases to 20 to 25%. Genetic conditions such as Downs increases as well. For as a comparison, at 25, it is a 1 in 1,200 risk. At 35, it increases to 1 in 350 pregnancies. However, 78% of even these patients in their mid and late 30s conceive within a year and can go on to have healthy pregnancies. 40s, again, it is dismal because it is declining at a very fast rate. Only 5% will have a chance of getting pregnant naturally. And the odds of pregnancy within a year are 40% less than half of what it was at 20. Miscarriage rates are very, very high. And most of these women definitely have to rely on ART to conceive. Effect of age also is seen in aneuploidy rate that we find, which increases, the implantation failures increase, miscarriages increase, and the affected childs have a very high aneuploidy rate also. This slide is very common. We all, as IVF specialists, are very fond of showing this slide, but it does tell us that, we have come to realize that as the age advances, you need more and more eggs to have even one euploid blastocyst. And actually to get this number is really, really difficult and very tough because these women do not produce that many eggs. We should be looking at this in our patients of 35 to 37, and this is definitely earlier than that, 30s. This is what we should be looking at in our patient pool. 42 to 43, definitely we don't have so many. So that is what is very important when we have to talk about unexplained infertility as well, which may be because of the age. The answer is that, the euploidy rate here at younger age is 60%, whereas it is very, very low at age when the patient has crossed 40 years. And so you really have to struggle to get that one blastocyst, which is going to produce a normal pregnancy. And as the study also in 2012 suggests that there is a higher aneuploidy rate in older women. And of course, the higher numbers of euploid embryos will increase with the cohort size. So therefore, this is a real catch-22 situation. You have to have more eggs, and you have to adjust to the aneuploidy rate also in these older women. So that is something that actually is very difficult for us to handle. And like it was mentioned with both the speakers earlier, the likelihood of pregnancy also decreases considerably, although we cannot really judge it in the Indian context. But however, the studies say that the likelihood is very low when the patient reaches this age later. And of course, the likelihood of infertility is definitely rising. So when a patient comes to you getting married late, or even for fertility preservation, if these girls are coming, you have to actually understand that, yes, age-related decline of fertility has to be described to them. The most important point is this transition period of human reproduction. Loss of fertility precedes the menopause by 12 years, and 10% of the women enter menopause in their early years. 1% of these women enter the menopause in their 30s, and basically they are actually starting off with very few eggs. So this is something which may be a reason for unexplained infertility, because they are young and they are starting with very few eggs. And so due to lack of symptoms, these patients will frequently erroneously be tagged with a diagnosis of unexplained infertility, whereas basically they are actually poor ovarian reserve or poor ovarian insufficiency. So there are two main mechanisms of premature ovarian failure or insufficiency. One is the dysfunction of follicular maturation, and the second is depletion of the follicular pool. And both of these they can be age-related, or they may be actually not related to the age, maybe acting faster than what it should be at a particular age. And so functional classification of premature ovarian insufficiency has been described as ovarian follicle depletion and ovarian follicle dysfunction. And you have these various defects which may actually be leading to either the depletion of the ovarian follicles or a dysfunction of the ovarian follicles, leading to a functional discrepancy in the way the patient behaves when she is put through any treatment, or even when she is trying naturally. she may try to conceive even at a younger age, and she may not be able to do so. So viral oophorytis, as you can see over here, is one such factor. And we know now with COVID that such things are coming up much faster. Insufficiency, as Escher described in 2015, is basically defined by an ovarian activity before the age of 40. And it is classically characterized by menstrual disturbances with a raised gonadotrophin and low estradiol. The term premature ovarian insufficiency should be used to describe it, this condition in research and clinical practice. Why you should not be calling it premature menopause? Because the patient is definitely, like Dr. Nirmala and the others were saying, then if you tell a young woman that she's having premature menopause, she's really going to be very upset with you. So premature ovarian failure, on the other hand, is basically oligomenorrhea for at least 4 months and an elevated FSH level of 25 or more on 2 occasions, 4 weeks apart. The cutoff is, of course, as we all know, 40 IU in POF. Now, the problem is that we have to actually understand and try and rule this out if we are going to talk about unexplained infertility. When you take the history, there may be a family history of early menopause, abnormal ovarian function tests with decreased oocyte quality, a low AMH and AFC, an elevated baseline FSH level, atypical resistance to ovarian stimulation with gonadotrophin. So basically, we all know this from the Poseidon criteria now, but it is very important to timely and correctly diagnose these conditions in these women, because if we are going to lose this window, we may miss the bus for them. POA is actually associated with alteration in the ovarian endocrine function due to aging of the granulosa cells and the theca cells, also because of an impaired microcirculation. And if it is diagnosed correctly, and if their infertility treatment is geared towards their ovarian rather than their chronological age, then the results of IVF could be excellent. So IVF will help reveal the premature ovarian aging and will also therefore act as something which is explaining the unexplained. So that is why when you're not getting anything out of IUIs and ovarian stimulations, then it is better to ask the patient to go through an IVF in order to understand what is actually happening to this person. We come therefore to the other important point, that is the luteal phase dysfunction. And actually this means progesterone. And we know that progesterone is the most tricky hormone that we are all facing these days and we are talking about all the time. Progesterone, we know, is mainly responsible for the endometrial secretory transformation and for the establishment of receptivity. But it also affects the ciliary action and the muscular contraction of the fallopian tubes, thereby facilitating the embryonic transport. Progesterone is associated with multiple molecular pathways and its actions are expressed through a complex network of downstream molecules. Progesterone function is reflected in changes at the level of the endometrium, which can be assessed through endometrial biopsy and endometrial rating. I'm glad that endometrial biopsy is now coming back. Most of us were very averse to doing endometrial biopsies earlier, but now that we know that endometrial receptivity is a major stumbling block in IVF cycles, more of us have started to do that. It also influences the pelvic organ perfusion by reducing the vascular resistance, which can also be assessed by ultrasound. So this is something about the progesterone, and let us see what we can do to help our patients, to help explain the unexplained. Now, I am coming to some of these studies which are very, very recent. This is an open access article from Dr. Roy Hamburg's unit in March 2023. This is a meta-analysis of unexplained infertility, where they have tried to see the endogenous progesterone. This study meta-analysis included 41 studies, and the number was 4,023. There was no difference found between the mid-luteal progesterone levels of women with unexplained infertility as compared to the fertile controls, And the women with unexplained infertility had significantly higher rates of out-of-phase endometrium. So therefore, they went on further to see that 9 out of the 10 progesterone-mediated markers of endometrial receptivity was significantly reduced in women with unexplained infertility compared to their fertile controls, and the remaining one had conflicting results. The resistance in the pelvic vessels was increased and perfusion of the endometrium and subendometrium reduced in UI compared to fertile controls in all the included studies. And the progesterone receptor expression and progesterone uptake were also reduced in women with unexplained infertility. Hence, it was deduced that basically it is not the level of progesterone which is down or which is not normal. It is the action of the progesterone which is not sufficient at the level of the endometrium. And therefore, they were looking at three things: reporting the progesterone levels. They were looking at ultrasound evidence of pelvic organ perfusion, and of course, the endometrial biopsy results. So finally, they concluded that the end organ measures of endogenous progesterone activity are reduced in women with unexplained infertility as compared to fertile controls. This is probably receptor-mediated reduction in response effects and it affects the endometrial receptivity and is implicated as a cause of infertility. So basically, it is the endometrium which is not as receptive as it should be to the levels of progesterone, which is probably causing that infertility. Another study of 2021, this is from Turkey. This also looked at the morphological features of the secretory phase of the endometrium in patients with unexplained infertility. And what they found was that serum prolactin was found to be relatively high post-ovulation in the infertility segment. And if you look at this over here in this group, you see that the serum prolactin over here in the infertile patients on the 5th day of the study, 6th day of the study, post-ovulatory, as well as the 7th day post-ovulatory was higher than their fertile controls. Similarly, in the same patients, when they got pregnant, this found that this was persisting. And in the patients who were not pregnant, they found that the fertile patients as well, compared to the fertile patients, this was very high. So they concluded over here that the serum prolactin in these patients become high, and that may be the reason it is affecting the endometrium. They looked at the morphological features of the endometrium, and what did they find was that they found that there is a presence of pseudostratified and stratified epithelium with patches in the surface epithelium, which is corroborating with an abnormal secretory endometrium. The abundance of cells with well-developed microvilli, sparse pinopodes and vesiculated cells, structural differences in pinopodes, diffuse intraepithelial lymphocytes, and a raised serum prolactin concentration. Hence, the endometrial epithelium indicated ultrastructural characteristics of the proliferative phase with metaplasia. So in both these, the first one was a meta-analysis. This is a study which is also looking very closely at the features of the endometrium. And they also found that the structural features of the fertile and infertile patients on day 5, 6, and 7 after ovulation was definitely different. And that may be the reason these patients don't conceive. Yet another one of 2020, this was another assessment of the endometrial receptivity during implantation window in women with unexplained infertility. Again, 7 to 9 days post-ovulation. What did they find over here? They were looking at the ultrasound parameters to see what is the endometrial receptivity like, and also the thickness of the endometrium, the volume of the endometrium, and also the ultrasound features to look at the perfusion in these. And what did they find was that here, the subendometrial, that means the flow of the blood flow into the endometrium was definitely different. In the unexplained group, it was lower. You find over here that the VI, the FI, and the VFI were all less as compared to the fertile group, and the biomarkers along with them, that means the biomarkers, for which progesterone is responsible, were again low as compared to the fertile women. So again, when these patients became pregnant, they found that the endometrial thickness, although in the non-pregnant, was much less as compared to that. The volume was also much less as compared to the infertile group. And as you can see over here, the perfusion indices were all lower as compared to the fertile group where the patients became pregnant. The biomarkers also suggested the same thing. Hence, all these patients with unexplained infertility presented with a declined endometrial receptivity. Endometrial ultrasonic parameters detected by 3-dimensional power Doppler and biomarkers in the uterine fluid may be effective indicators to predict endometrial receptivity. In this paper, what they did was that they put some saline into the uterine cavity, and then they flushed the uterus at the time of ovulation and tried to see what these biomarkers are in the fluid which they withdrew from the uterus. Then immunology. What do we say? What I have suggested, these biomarkers are partly the immunological markers that we are talking about. However, it is important for us to recognize that the fetus is a semi-allogenetic antigen, as a semi-allogenic antigen is crucial for the successful implantation. And therefore, there has to be maternal immune tolerance against the fetus. Only then will you get a successful pregnancy. Maternal immune tolerance needs alterations in the cellular and humoral immune responses, which are mediated through immune cells, cytokines, and chemokines in the decidua. And as the decidual immune system, which may be innate or adaptive, is vital for the acceptance, rejection of the fetus, altered proportions of levels of immune compartments could break their maternal immune tolerance and hence result in infertility, especially in cases of unexplained infertility. So basically, the immune system, in other words, has to be absolutely correct. It should be able to recognize the semi-allograft in the form of the fetus or the sperm itself in order to accept it. And then only can we have a proper pregnancy happening over there. And therefore, we are very familiar with the TH cytokines, the TH helper subsets, which is the TH1 and TH2 and TH17. And also the decidual humoral system, which includes the autoantibodies and the cytokines, such as pro-inflammatory and anti-inflammatory cytokines, which may play a role in female fertility. So this is a very interesting study, female unexplained infertility, a disease with imbalanced adaptive immunity, from our own journal, Journal of Human Reproductive Sciences in 2019 from Iran. And this basically tries to explain how autoimmunity and the change in the humoral and adaptive immunity is actually leading to a rejection of the fetus. And that may be the reason for unexplained infertility. So the TH1 helper and TH2 ratio and the number of T helper 17 are increased in females with unexplained infertility. And therefore, it induces a pro-inflammatory condition. The follicular helper cells number and production of interleukin 21 are increased, and the interleukin 21 production leads to a production of autoantibodies. The complications of antiphospholipid antibody production, we know, is high levels of thrombosis, inhibition of migration, and the implantation of the embryo. Therefore, an anti-ovarian antibody also adversely affects the growth and progesterone production in the granulosa cells in the antral follicle. So the antithyroid antibodies also adversely affect the thyroid hormone that leads to inhibition of migration and promotion of endothelial thrombosis in these patients of unexplained infertility. And that is why our forever debate with the endocrinologists is when they say that the antithyroid antibodies are not going to affect anything, whereas we as the reproductive endocrinologists are saying that we do have to look at these antibodies also, because they may be having an adverse effect at the level of the endometrium or in the reproductive system as such. Autoantibody also we all know, is a process of self-destruction, and therefore these antibodies definitely have to be taken into consideration when we are talking of this state within the endometrium, which is going to give rise to a pregnancy. So very interestingly, this paper from France came out in 2022, where they looked at 1,788 patients they did an immune profiling on a timed endometrial biopsy between 2012 to 2018. That means over a period of 6 years, they looked at so many samples of endometrial biopsy, and they actually documented the presence or absence of endometrial immune dysregulation and identified its type. So based on the type of dysregulation, a targeted personalized plan as to what should be given to these patients was suggested. And then the treating clinician was informed and aimed to supply the anomaly. So after giving the required treatment, they found that the pregnancy rate was significantly higher if an endometrial dysregulation was found and a personal plan was applied. compared to patients with an apparently balanced immune profile, respectively, 37.7% against 56% versus 26.9% and 24%. And what did they find was that 16.5% of these patients showed no endometrial immune dysregulation, 28% had a local immune underactivation, 45% had local immune overactivation, and 10.5% had a mixed endometrial profile. So basically, based on this kind, which is elaborately detailed in this paper, they proposed a plan, and based on that, as to what treatment to be given to these patients, and based on that, they got a very good pregnancy rate. So this is also worth considering. Then, of course, we all know that ovarian stimulation has a very big impact upon the hormones. The hormones have a very big impact on the ovarian stimulation, and they also impact the microbiome and the susceptibility of the woman to infection. Now, I'm coming to that aspect of immunity as well as ovarian or oocyte problems. So in 2008, Jacobson and Forsum evaluated the changes in the predominant human lactobacilli during IVF in order to see the difference in the vaginal flora due to differing estradiol levels in the plasma during ovarian stimulation as a part of IVF treatment. And they found that hormone-dependent microbial shifts may be having a bearing on the pregnancy outcomes. So by using the usual 16S and RNA deep sequences, the authors reported that there is an induced shift in the vaginal microbiome in some, but not in all the samples of the women. And therefore, they said that this may actually be leading to the failure of pregnancy. And this is what they found, that these changes are predominantly in the human lactobacillus during fertilization is what they found. And they found that these hormone-dependent shifts during the process of ovarian stimulation actually have a bearing on the pregnancy outcomes. And interestingly, this paper of October 2019 shows that there is a huge correlation between the hormones, the immune system, and the mycobacterium. So everything is shifting as the hormones keep on changing. You see over here that this profile of immune cells is different in the estrogenic phase, and it is different in the progesterogenic phase. And basically, if the secretory endometrium is good and the microbiome is also normal, everything will be normal. However, if anything is disturbed, then you will find that all of this is going to go for a toss. And interestingly, this paper is very old. It appeared in 2007, which tells us that the level of estrogen in the body actually decides the so the immune factor, the immune regulation within the body. So basically, the E2 levels in pregnancy, as we know, are higher. And with that, what happens is the different kind of cytokines are upregulated and downregulated. This means the downregulated ones, and these are the upregulated ones. Whereas in the postmenopausal woman, where the E2 levels are very low, you find a different kind of profile over here. So that could also explain why our patients who are aging or having premature ovarian insufficiency may be having different kind of estrogenic activity and immunological activity in their bodies, giving rise to this kind of a problem with infertility. So also this is basically to explain the same thing, which can lead to chronic inflammation within the body. And of course, majorly the role of progesterone, as we all know that the progesterone is basically responsible for the opening of the window of implantation, and it actually induces T cell activation, induces tolerance, and induces a tolerance at the maternal fetal junction. It decreases the cytotoxicity of the T cells, and therefore it is responsible for making the whole system more tolerant to the incoming fetus. That is, these are the factors which also may be responsible for what is happening within the endometrium. And finally, the final part that Madhuri had told me to talk about, oocyte quality can be affected by anything: age, stress, environmental toxins, nutritional status, infections, cause of infertility, type of patient, COS protocol, drugs, lab conditions, and of course, if we keep these all together, it would be unexplained. So therefore, anything can happen at any stage affecting the oocyte quality. We've discussed all these factors, and yes, any of them can cause oocyte problems as well as embryo formation therein. And so we have to be very, very careful. They have actually also found out many markers over there, which are regulated by FSH and LH, and therefore a poor response with gonadotrophin has also been defined, which may be causing this kind of a problem. So finally, I come to the last slide, which says that in order to have better results, we should improve our diagnostic accuracy. Of course, if we are improving our diagnostic accuracy, the problem of unexplained infertility is no longer going to be unexplained. We would have explained everything. But at the same time, as Dr. Nirmala has said very nicely, nothing is evidence-based. So all of this that we have discussed today in my lecture, as well as Deepak's lecture, is not evidence-based. So when we have to deal with our patients, we have to keep it in mind. And so we do have to keep on evolving with science as it emerges, but at the same time, be cautious of the fact that we should not be harming the patient by trying new medications of which we don't have enough evidence. So basically track down, see what you can manage with whatever you have, which is proven and evidence-based, and then go ahead and make your patient understand that she is in the category of explained yet unexplained, and I shall be treating you like an unexplained infertility. I thank you very much for your attention.
Thank you, Sonia, for that excellent lecture. And we have the questions after the next talk. So we have now Dr. Pratik Tambe. Who would be talking to us on management of unexplained infertility. He's a ART consultant and gynec endoscopic surgeon, who was trained at Belgium, France, and Singapore. He's the chair of EMOX. He was the chair of EMOX Endocrinology Committee. He's a governing council member of ICOG. He's the managing council member and patron of Mumbai OBGYN Society, and also the managing committee member of ISAR and Maharashtra State Chapter. He's also been the past chair of FOGSI Endocrinological Committee, and he has several awards to his credit, and he would talk to us on management of unexplained infertility. Over to you, Pratik.
Thank you very much, ma'am, for introducing me so elaborately. Let me begin by sharing my screen and thanking our ICOG chairperson, Dr. Lakshmi Shikhande, Vice Chair, Dr. Parag Biniwale, and of course the Secretary, Dr. Ashok Kumar. I must also thank Dr. Madhuri Patel, who is the convener for this excellent ICOG Masterclass on unexplained infertility. So I'm here today to talk about a topic at the fag end of the program and try and make sense of everything that you have heard so far, and to understand how much of what you have heard is evidence-based, how much of it is research, what can actually be put into clinical practice. And the most important of all is, when we treat these patients with unexplained infertility, are we actually doing some good? Are we harming them? And what is the cost-benefit ratio for whatever treatments that we actually offer them in clinical practice? I like to start with quotations. So today's quotation is from the American educator, Noam Chomsky, who said once upon a time that the willingness to be puzzled is a valuable trait to cultivate from childhood to advanced inquiry. I'm sure all of us have been puzzled by so-called unexplained infertility. The vast majority of my balding and gray hair probably comes from trying to treat infertility patients and understanding what is going wrong and try and solve their problems in the shortest possible time to give them good results. I like to always start by asking whether whatever I'm speaking on, whether it's relevant to clinical practice or it's just an abstract theoretical concept. And if you go back to literature and see, there is a plethora of guidelines regarding unexplained infertility, and I'll just go over them in brief. The first is the NICE guideline, published way back in 2013. There's an excellent systematic review which was published in 2016 by the American Society for Reproductive Medicine. There's the Canadian Fertility and Andrology Society guideline, which is published in RBM Online 2019. That's the reference for you in case you want to look it up. There's the ASRM Practice Committee recommendations, published in 2020. And last but not least, the most recent of these is the Eshere draft guideline on unexplained infertility. You can see here from the website, this is a screenshot from 2 days ago when I actually prepared and updated my existing lecture on unexplained infertility, that this guideline was open for stakeholder review until very recently. And the final guideline is expected very soon in the next few weeks. So I will be mainly focusing on the last three. That's the Canadian Fertility Guideline, PSR and Practice Committee recommendations, and the draft ESHRE guideline, which we hope we'll be able to see in the next couple of months or so. All of these are public domain. They're easily available. Can't find them, feel free to write to me. I'll be happy to share a copy with you by email. So this is what the draft guideline from ESHRE looks like. Of course, as I said, the caveat is that this is not the final version and the recommendations may change in the final version. So please don't hold me to that. The starting point for discussion, of course, is to talk about what is unexplained infertility, which has been dealt with already by several excellent speakers who came before me. But chiefly, we need to prove that there is apparently normal ovarian function, that there is no physical abnormality or pathology in the fallopian tubes, uterus, cervix, and the pelvis. There has to be adequate coital frequency, absolutely normal testicular function, and a normal ejaculate. These are the basic requirements, and they have been laid down quite some time ago. It goes without saying that doing baseline hormonal testing is something which is of vital importance in proving that the hypothalamus, pituitary, ovarian, and endometrium axis is documented to be normal, because a lot of subtle hormonal pathologies can be missed. And when the patient comes to you, that's one of the first tests that you need to do. As per the ESHRE draft guideline, there are a lot of investigations which we do in clinical practice, but they say don't really merit, how can I put it, the patient's time, attention, and expense in 2022. And of these, the tests which they say, which you see in the second column highlighted in the red, other tests which we should not be doing. Of course, this is controversial. We discuss them a little later, but they say that luteal progesterone, endometrial biopsy, ovarian reserve testing, MRI, postcoital test, testicular imaging, anti-sperm antibodies, DNA fragmentation tests, TPO antibodies, thrombophilia testing. These should not be routinely offered to patients who have unexplained infertility. We know, of course, that from clinical experience, several of these tests, and the previous people have already highlighted this, are very much warranted in clinical practice. They may not yield results every single time, but the vast majority of times we find that the incidence of abnormalities in this test is significant enough that we tend to offer it. For example, ovarian reserve testing, which you saw, Dr. Sonia Malik gave an excellent talk that unexplained infertility often can hide premature ovarian insufficiency, and you will only pick that up if you do specific testing for those issues. Similarly, for male factor, you heard a little while ago that doing your DNA fragmentation, semen morphology, etc., all those tests, we don't do for everybody, but in those patients where you suspect, you should definitely be doing that. ICOG, HSG, and 3D ultrasound are very much in the green zone, and everybody should undergo them as per ESHRE recommendations. Now, once upon a time, when I was a young man, I used to think that unexplained infertility chiefly falls into two different broad categories, either failed fertilization or failed implantation. It was an oversimplification, and we know today, and with experience, I've learned that the categories are much more broad than these. But for practical purposes, when you are explaining to a patient, these are two categories which you can definitely focus on during your counseling sessions. Which brings us to what are our treatment options. And you will notice that I put the word treatment in brackets. And there is a very specific reason for it, because some people feel that offering no treatment is probably the best course of action. In fact, from our armamentarium and the alternatives that we offer our patients, right at the top is to do absolutely nothing. Again, this is controversial, and we will qualify that in the forthcoming slides over the next 5 minutes. There are other options, of course, which are available, and these are evidence-based. They include endoscopic procedures, pharmacotherapy, active treatment with ovulation induction and IUI, and of course, finally, at the end, we have IVF and FOGSI. So which of these are actually useful and beneficial, and in which particular patient you should be offering these. That is where your clinical
I think Pratik, you're frozen.
Pratik is lost. Pratik is not there.
He will come back.
will get pregnant without any intervention over a period of 18 to 24 months, you will realize that the cumulative pregnancy rate over 2 years can be as high as 72% in young women and young couples who have a shorter duration of infertility. This, of course, declines to less than 45% in women who are older than 35, which is the vast majority of women in my practice. It may be different for you, it may be different in the area that you practice. That's a different story altogether. But the key is that it's less than 30% in couples who have long-standing infertility. And by that, we mean more than 5 years of infertility. I don't know who would wait for more than 5 years in 2023 before they consult a doctor or they go to a fertility physician. But it seems that there are couples like that. There are certain authorities who feel that the common sense approach is to do absolutely nothing. And one of these is Professor Shiladetta Bhattacharya. Way back in 2008, he did a landmark RCT, which was published in the BMJ, where approximately 200 couples were randomized into each arm. So totally they had about 600 couples. The first arm was expectant management. The second was oral clomiphene citrate. And the third was an unstimulated IUI. And they did this for 6 months consecutively, and they assessed the results of that particular approach. They found that the live birth rate for expectant management was around 17%. For clomiphene citrate, it was approximately 14%. And for IUI, it was 23%. The most important words are on that last line in brackets. The difference between clomiphene, IUI, and expectant management was not statistically significant according to them. Therefore, they say that in young couples, where otherwise everything is normal, leave well enough alone, and the results from the wait and watch approach will be exactly the same as you wanting to intervene in the best interest of the patients, and ultimately you may not be able to give a better success rate than another nature. Therefore, the Canadian Fertility Guidelines says that in couples with good prognosis, based on the duration of infertility, expectant management can be offered. This is level 1A, strength of a recommendation. Let's talk a little bit about endoscopic procedures. And it's pretty much commonplace today to see that a lot of couples are undergoing cycle after cycle of stimulation without anybody actually having a look inside to see on laparoscopy and hysteroscopy that everything is fine or not. And the reason for this is you can do an HSG today, you can do a 3D ultrasound, you can do a ICOG. All three approaches are very much endorsed by the HTA guideline. And even ASRM says that in the absence of tubal or otherwise obvious pathology on HSG or ultrasound, laparoscopy is not warranted. But they go on to further qualify this statement by saying that there may be a place for diagnostic laparoscopy in young women who have a longer duration of infertility, which is more than 3 years, where you're going to find subtle abnormalities. For example, you might find stage 1 or stage 2 endometriosis, you might find tubal issues, and these may not always be obvious on your standard HSG or ultrasound, and that's where you would need to subject the patient to hysteroscopy. The next approach is timed intercourse of land relations. Now, you've already seen what Professor Shiladetta Bhattacharya says, that it's absolutely useless. And there are many other authorities also who have done prospective trials. And the meta-analysis of that, as per Eshley, is that clomiphene followed by timed intercourse is not recommended over expectant management in couples because the results are exactly the same. There's no difference. So don't just be busy. Don't just be appearing to do something, make sure that whatever treatment you're offering is actually beneficial to the patient. The next option is whether we can do IUI, and to save on cost, and we do something called as a natural cycle IUI or a minimal stimulation IUI. That was one of the options which was available once upon a time. And Ashray feels that IUI in a natural cycle is not recommended as far as management is concerned. It doesn't give significantly better results. And this is a very strong recommendation against natural cycle IUI. What pharmacotherapy can we actually offer our patients? Can we offer all this masala which our medical representatives are telling us that my combination of antioxidants is the best? This is the new thing on the block and this works best. This works very well. So adjunct oral antioxidant therapy, either for the female or the male partner, is probably not recommended. Again, inositol supplementation, as per Ashray, is probably not recommended in patients with unexplained infertility. There is a time and a place for them, but in unexplained infertility, they probably do not significantly impact your live birth rate. And that's what is important. So after all these boring slides where I'm saying this is not recommended, that is not recommended, what is actually recommended? What I should say is that psychological support, psychotherapy, healthy diet, regular exercise, cognitive behavioral therapy, positivity, mindfulness, all of these are very much important and they are supported by the guideline. Now to the important part of the talk, the last and the most significant part, and that is what kind of ovarian stimulation should we be offering these women and does it actually work? Now, IUI combined with ovarian stimulation is highly recommended over expectant management in couples. And as you have seen, if you're not looking at those couples who have a shorter duration of infertility, younger couples, the moment you're looking at somebody 30 plus, where there are multiple factors, where they have a longer duration of fertility, don't waste time with clomifene.
We can't hear you, Pratik. Pratik, we can't hear you.
His internet is gone again.
Shall I call him?
For the poor internet, let's go back and share again. I think I was at this point where we were talking about the stimulation protocol. So which stimulation protocol is recommended? And this is the Amigos trial, which was published in 2015. They had 900 patients who were randomized to 3 arms. And they found that they had higher live birth rates in the clomiphene group as compared to the letrozole group. So by and large, though we use letrozole as the first line in clinical practice for PCOS patients, in unexplained infertility, clomiphene seems to work better. Clomiphene versus letrozole difference, though you can see, is 18% versus 23%. It was not statistically significant. But the results from the gonadotropin group, which were 30% plus, were statistically significant. And this was one of the important trials, Diamond Richard Legros et al. And that's the reference at the bottom in case you're interested in looking it up. So gonadotropin IUI is highly recommended for couples with unexplained infertility. Patients should be aware that gonadotropins can lead to a higher multiple pregnancy rate, high clinical pregnancy rate per cycle, and of course, in the rare instance, they can cause OHSS as well. This is something which needs explain to the couple and IVF give better results vis-a-vis IUI? That's the question which is on everybody's minds, and that's the million-dollar question which we need to answer. And the issue is that IUI is recommended for couples with unexplained infertility. Overwhelming strong recommendation from HPH. But as far as IVF is concerned, there is disparity in the findings from all three guidelines. Now, Eshere says IVF is probably not recommended over IUI because the results are probably exactly the same. And IUI is a more cost-effective procedure as compared to IVF. Now, the Canadian Fertility Society guideline has an excellent meta-analysis of all different studies ranging from 2017 all the way up to 2000. And it looks at gonadotropin IUI versus IVF. And they feel that IVF can be offered as an effective first-line treatment. This is exactly the opposite of what the HTA guideline is saying. So it's controversial, but I'm sure that most of us will agree with the second statement that the Canadian guideline makes. And that's that IVF should be offered to couples who have unexplained infertility after 3 cycles of gonadotropin IUI have failed. I think this is pretty much common sense, and this is what all of us practice in clinical practice. Therefore, I think that's something which we should bear in mind. As far as cost effectiveness is concerned, IUI cycles are more cost effective than IVF. That's what ASRM says. And there is no difference in the live birth rate when you compare IUI and IVF in unexplained infertility. Therefore, they are more in favor of offering gonadotropin IUI as compared to IVF in these particular subset of patients. So you can see 2 guidelines recommend IUI over IVF. The Canadian guideline is the only one which recommends IVF over IUI. Now, is ICSI better than IVF? Overwhelmingly, no, it is not recommended over conventional IVF. That's what Eshere says. But then you and I know that in clinical practice, guidelines is one thing. It would be a very brave clinician who says that don't do ICSI to his embryologist, because they're always afraid of failed fertilization in these patients. We don't know what is the issue. And sometimes it can be an issue with the sperm, which is undiagnosed. And you don't want to be the one person who says, no, the guideline says IVF is better than ICSI, but in clinical practice, we may actually do something different. One last slide about what is relevant to the Indian context. And this is just a short list of different issues which you may encounter in clinical practice, which Western guidelines may not always cover. Although Eshere says that endometrial pathology is not an issue, don't do hysteroscopy, don't do biopsy. Tuberculosis is quite rampant in our country. Subtle endometriosis is something which we see more often than not. Because of environmental pollution, we are seeing higher rates of DNA fragmentation, reactive oxygen species, abnormal semen morphology, all of these. And from Dr. Sunamalik's lecture, you also know that premature ovarian insufficiency is quite widespread. Undiagnosed POI actually is what I should put on that slide, not just regular POI. We even have youngsters as young as 25 and 30 coming to us with POI. So to conclude, ladies and gentlemen, the key practice points. Expectant management is an option, but only in certain classes of patients. Those who have a short duration of infertility, who otherwise don't have any demonstrable pathology, and where you expect that per cycle fecundity is going to be 5% or higher. Natural cycle methods don't work, whether it's timed intercourse or natural cycle IUI, it's not something which is beneficial. Gonadotropin IUI highly recommended by most of the guidelines. IVF may not necessarily give you better results than IUI. ICSI, as per the guidelines, is not recommended, but we just talked about it 2 minutes ago. And the most important line on that slide is the last line. Please wait for the final Eshere guideline, because these recommendations may change. And then I will be in a suit, because you will say, Dr. Pratik, they said, don't do this, don't do this, don't do this. So I'll close. And thank you very much for having me here. I hope I have added some benefit to this wonderful masterclass. My name is put together. Apologies for the internet issues. And thank you again for this opportunity.
Thank you, Pratik, for that excellent lecture. But what today they say is that, your treatment for unexplained infertility basically should depend upon the age of the patient. So in the Indian context, if we have a patient who is more than 35, I think IVF would be the first choice. If she's less than 35, probably we need to go for ovulation induction with clomiphene. And the newer guidelines prefer saying that instead of going for 3 cycles of ovulation induction with CC and then 3 cycles with gonadotropin and then IVF, it is better to go for CC with IUI for 3 cycles. If she does not conceive, go for IVF because it shortens the time to pregnancy. So I think that should be the conclusion on the management. So there's a question for you, Sonia, as to role of ERA, Emma, and Alice in clinical practice.
Well, thank you. Actually, it has become rampant. We are all using it. But I would say again, when you look at the original paper that they published for ERA and Emma, there were only 16 patients. Lives we had been struggling with our own infection of tuberculosis, but nobody acknowledged it. So it's like that, So basically, I would say that these tests are reserved only for people who are doing advanced reproductive medicine, like you're having patients for IVF and you're looking at that. But I wouldn't say that these tests should be done at primary level. One, because they are very expensive. And then sometimes you don't know what is the, how to interpret these, at that primary level. And therefore, we have to now learn to that microbiome has become a very big thing. And so also the endometrial receptivity because of the ERA test. But of course, we also know that there are pitfalls with the ERA test. Not everything is very clear over there. There have been so many papers now which are actually trying to tell us that all is not as rosy as was suggested in the first paper that came out. So I think evidence is still evolving and we have to go with it. And initially I was doing a lot of ERA, but now I'm not, because I find that, even without that, we can do as good. So I think we will have to really wait and watch and see how things shape and then decide what should be good for our patients. And very rightly, as Prateek has said, the Indian context. All of us have actually been saying that, Indian context. So, and I think the next question that Dr. Anjana had asked is, should we be doing an EB? I am a great proponent of endometrial biopsy. I keep on doing endometrial biopsies right, left, and center to see what is happening over there. But that is also not correct for general practice, because you have to restrict it to, when you're trying to do some advanced management, yes, you can think of all these things like TNF-alpha and integrin and cytokines and this and that, but not at primary level. No, I don't advise that at all. Of course, the best thing is to rule out endometriosis, look at the histopathology and forget about it after that. Yeah, that is all that the role of endometrial biopsy is.
Yeah, so there was a recent paper in Fertility Sterility which was published in December, which looked at ERA. And what they said is that probably ERA really does not have a role.
Absolutely.
And I have done in about more than about 50 patients, and I really did not find it to be really useful. So I've really stopped doing. And if you talk about Emma and Alice, I think they're too expensive. You have to spend at least 45,000. So if you feel, because if you do a very good 3D ultrasound, you can feel that the margins, the endometrial myometrial junction is slightly irregular if there's endometritis. So I think these patients, we can just give them doxycycline for 15 days, because many a times when we do an endometrial biopsy also, we really cannot detect infection with them, because, and what you need to, all the histopathologists really will not go greatly to see the plasma cells and all. So I think if you do a good 2D and a 3D ultrasound where you can detect some amount of endometritis, it's best to give them 15 days of doxycycline. And for microbiota, probably you can always give them, supplement them with
What is also important from the ERA and Emma point of view is to understand that our microbiome in India is very different from the microbiome of the West. There is a beautiful paper from Guwahati, from Assam, where they have looked at the vaginal microbiome of all the different regions of the country, north, south, east, and west. I will send you the reference, Madhuri, you can pass it on. And there, you see, the lactobacilli are different for different regions. So this also is a very big insight for us. If you have an Assamese patient whom you're treating in Delhi, you have to treat her with different kind of lactobacilli because her microbiome is different. So how can we say that ERA and Emma is the best thing for us? We can't.
No.
That is why I'm saying that the evidence is still evolving and we really have to wait patiently for that.
Dr. Ranjana, you wanted to say something? You can unmute yourself.
जिग्नेश उनको अनम्यूट करने दो डॉक्टर खन्ना को.
Yeah,
Mhm.
actually, Dr. Sonia, good evening, everyone. Dr. Sonia, that was a wonderful talk, and Prateek, that was wonderful too. I just wanted to clarify about this because I remember when I was doing my MS in the beginning, like in that time, it was told premenstrual endometrial biopsy is a must, and then premenstrual went out of vogue because some patients came out to be pregnant. So it was EB on day 1 of the cycle. So that we continued for so many years, but we've stopped it now because apparently the ESHRE guidelines were saying that no, you should not be doing it routinely. But then the role of endometrial scratching is also coming up. So I just wanted to know in what are the cases when you should actually be doing, and should we be doing the EB on day 1 of the cycle or not?
Endometrial scratching, there's no evidence now. There were several papers, multicentric papers which have come, and they said that there's no role of endometrial scratch.
Okay.
So there are multicentric trials which have been published on.
Okay.
I
And
think
so what
endometrial
is your
biopsy-
recommendation for EB?
Endometrial biopsy today is very clearly stated as an obsolete test and has
Yeah.
got no role in today's era.
Exactly, because I'm not doing. So today that topic came up. So
You
I
are
just
right if
wanted
you are not doing an EB. We are only causing damage, not understanding.
so
anything.
yeah.
If you feel when you're doing a hysteroscopy and if you feel that there is there are signs of endometritis, I think you should go ahead and do an endometrial biopsy because we know that tuberculosis is common in India.
Yeah.
And
Yeah, that's what I wanted to say, because it
so
was
you should not
initially.
do it in all patients. So you should do a hysteroscopic guided endometrial biopsy wherein you've done a hysteroscopy.
Madhuri, that is not going to help because at that time on 8th and 9th or 10th day of the cycle, the mycobacterium is silent. It's not even, there won't be any granuloma over there. It takes 22 days for the whole thing to come up. So if you're doing it in that phase, you won't get anything. It will be false
No,
negative.
day one.
Day one is the best time. Day one is the best time, not with hysteroscopy. No.
See, I remember that it was very mandatory that first do the endometrial biopsy, and if she is tubercular, then don't go in for a histro, because histro is going to disseminate the tubercles all over. So it was mandatory to do an endometrial biopsy before you went in for tubal testing. So now,
I think when Deepak was suggesting that we should have our own guidelines, and I think Lakshmi is listening to us debating on this. You know what? Basically, ESHRE and ASRM is saying that we should have these 3 things mandatory. In view of our own infectious environment around us, we should add endometrial biopsy to it. Endometrial biopsy, tube testing, semen analysis, and ovulation. That should be done, and if that is negative, then it is an unexplained.
Unexplained.
I feel so, but I'm not. I mean, it's up to the whole
That's
house.
what I was thinking, that if we do histro without knowing the tubercular status of the patient's endometrium, won't we be spreading it further? I mean, naturally, tubercles will go to the peritoneum then.
Tubercles like that will not go. I mean, if there is some amount of intrauterine infection, there is always some amount of endosalping infection. It's always there.
Yeah.
So basically it is associated. So just by doing a hysteroscopy, you're not spreading the infection.
Not hysteros. I was talking about HSG actually.
But everything is same. Either you do a HSG or this thing, anyway putting a fluid. So whenever there is, so it is a evidence, because usually it is said that it's, I mean, if there is endosalpingitis, then there is endometritis, or there's endometritis and there's endometritis. So because the, it is in connection with each other. So I don't think it really makes a difference.
So what is the final recommendation by the expert IVF people sitting here? To do or not to do? Again, my question.
I would not do on first day. I basically, I do it, means that I'm telling you what is this view on it, is I do it in a patient where I'm doing a hysteroscopy, and I find that there is definite, there are signs of infection, or when I've done a 2D or a 3D ultrasound and I find that the endometrial myometrial junction is irregular, in those patients, even if I don't find anything on hysteroscopy, I would do an endometrial biopsy.
Sonia ji.
So, but I am a strong proponent of endometrial biopsy. I always do it. And in my unit, we are going to the extent of looking for CD138, which is a marker of endometritis. Now, again, I said we are doing it at that level because we are looking at IVF from that perspective.
Yeah.
It is not something that has to be done for every patient, only histopathology and basic. See, we are talking of subtle luteal phase dysfunction. Are we in this webinar only? So how are you going to see it if you are not going to do a biopsy? They say that it is not repetitive, but it is repetitive. We find it. And so many patients you will find that the corpus luteum, the follicle is not rupturing and she's having a problem so many times. So basically, I think it's worthwhile doing one biopsy and seeing that everything is all right. What is the harm in just doing it once? It's very simple and OPD procedure. But of course, it's everybody's own opinion. Prateek is smiling, so Prateek
Dr. Prateek, I would love to have your opinion too.
Okay, so this is off the record and this is experience-based medicine. This is not evidence-based medicine. There are 6 or 7 tests which I do for all patients who have so-called unexplained infertility. TSF, prolactin, AMH, semen morphology, DNA fragmentation test, a laparoscopy to rule out endometriosis, and the 7th is an endometrial biopsy to rule out endometrial pathology. These 7 tests I do for all Indian patients.
Right.
This is not evidence-based medicine.
It's fine, it's fine. It's practice-based, no?
Yes.
That is what I want.
Yes, it's clinical, yes.
I think there's a question for you, the role of probiotics in unexplained infertility.
I think when you have a question of microbiome that comes in and you're seeing that persistently the patient has a thin endometrium or that she has unexplained recurrent implantation failure, in those patients, yes, the microbiome is something which we are seeing more and more coming to the fore as far as creating a good, positive, healthy environment for embryo implantation is concerned. But that's beyond the scope of today's discussion. We are talking about unexplained infertility. We are not talking about recurrent implantation failure. That's a different matter about it.
No, so they're asking probiotics and unexplained infertility. They could be.
So what I could say is that there is no harm. Absolutely. There would be no harm in giving them, but that's not something which I would consider as the primary therapy. The primary therapy is to ensure that you have a good quality oocyte, good quality sperm, a healthy environment for blastocyst implantation, which means that you need to have the best quality egg and sperm and endometrium to get positive results in these patients. All the other masala will come in afterwards. First, these 3 important things, it's your duty as a clinician to ensure.
So if the patient is going to undergo hysteroscopy and endometrial biopsy, which day of the menstrual cycle is better?
Depends on why you are doing the hysteroscopy. Depends on why. You see, you also don't do it and I also don't do it for every patient who is coming for IVF. We don't do it. It's only when it is indicated we are doing hysteroscopy. I don't, at least. Everything is visible on 3D ultrasound. If you have a good sonologist, she'll tell you everything. So you don't need to do it for structural defects. If you think that you are looking for some kind of endometritis, you want to go in and look at the strawberry appearance and all that, hyperemia, etc., you can go and do it on any day, 9th day, 10th day, it is going to remain all the time. But I was specifically talking of granulomas and tuberculosis. They don't become evident before 22 days. So that's why. But of course, yes, the usual thing is what is actually written in the textbooks is that it should be done around the 9th, 10th days, just as we do for HSG. Same way, we have to do it for hysteroscopy also. But everybody is doing it at different periods, premenstrual, postmenstrual, mid-cycle, whenever they want. So it's all dependent on what you are looking for.
Dr. Lakshmi, you want to give any comments?
No, Madhuri, I'm just appreciating your efforts, your selection of topics and the speakers, and clearly every speaker has given the take-home messages and the evidence-based and also the practice-based messages to our audience. And I'm sure each and every delegate must have been benefited by this masterclass on unexplained infertility.
Yeah, so Dr. Ranjana has said that EB should not be done that late. Yeah, so actually, basically, we are not sure if the patient is pregnant, and therefore you should not do it in the luteal phase.
Correct.
So therefore, I think people did it on the first day, but I'm never a proponent of doing a EB on the first day or this thing. So everybody has their own
Everybody has their own ways.
ways of doing it.
That is why, that is why we are so confused in infertility and everybody's going their own way. We don't have any set method.
Their own experience based practice we are doing, and sometimes I think that is good also, because patient things are different. I mean, my Nagpur patients will have some different characteristics, your Delhi patient will be having some different characteristics. So
Absolutely.
sometimes when apart from evidence based, we do have to use our experience in managing these cases.
Yeah, true.
Yeah, but one thing I would just like to say that please don't use multiple drugs, because we have prescriptions which come with 3-4 progesterones, and they give steroids and they give God alone knows what masala. So I don't think that's a right practice. So I think that's the most important message I would like to give. I mean, there are some things, don't practice everything evidence-based, but I don't think there is a role of any of these masalas, what everybody gives, and even they give sildenafil, they give this, that. A prescription is almost about 20 drugs. I think we should not only think about what the outcome is going to be, but we should also think about the patient's pocket, because we know that these patients are so stressed. And then on top of that, you're making them use so many things. So that's even comes in a woman with PCOS. So where you give so much, you give myonisitol, you give metformin, this, that, where there's not much evidence, and there are companies who come and tell you give everything, put arginine, this, that, put together. And if you look at the pharmacokinetics, if you mix all the drugs and give, I don't think they really have a great action. So each drug has its own pharmacokinetics, and one has to look into it. So I think it's best not to use combination of drugs also.
We really don't know anything about the drug interactions. When we are giving 20 drugs, we really don't know what effect they are having on that woman.
Pratik, you want to say something?
Yeah. Pratik.
Yes, ma'am. Regarding the timing for endometrial biopsy, there's a lovely paper which I read recently, which has proven that a biopsy which is done when the patient is menstruating, you will have two different sources for your PCR. One is the endometrium, which has been recently shared, and the second is the menstrual blood. And if you combine the results of both, you are much more likely to get a healthy yield and a positive result and diagnose mycobacterium tuberculosis better. Vis-a-vis doing it post-menstrually or immediately premenstrually, this approach is supposed to work better. So the old teaching of doing an EB on day 1-2 of the cycle indirectly has now been proven right by evidence-based medicine by recent papers.
Pratik, I have to differ from you here, only for the sake of PCR. For PCR, you are not doing menstrual blood. That has got too many inactivators, and therefore they interact with the upregulation of the complement that you're going to use for PCR. But of course, menstrual blood for culture, AFB culture, yes, you can do it, but not for PCR. And CBNAT also, they strictly say that there should not be a single drop of blood over there if you want a correct result. So
Probably
that correction, yes.
Culture would be a better option than doing
culture, yes, than PCR.
So if we don't have any more questions, I would like to thank our chairpersons, Dr. Shobna and Dr. Rita, and all our speakers, Dr. Sujata, Dr. Deepak Modi, Dr. Nirmala, Dr. Sonia, and Dr. Pratik for excellent deliberations, and all the audience to be here, and for the questions that were raised. And not the least, I would like to thank Dr. Lakshmi for giving me this opportunity to convey this masterclass on unexplained infertility. Thank you all.
Thank you very much. I would like to thank Madhuri for bringing out this beautiful masterclass, crisp and precise masterclass on unexplained infertility.
Thank you so much.
Thank you for having me.
Thank you so much. Thank you.
Thank you for having me. Bye.
Thank you.
Bye. Let's stop the recording. You can.
Thank you. Thank you all. Thank you, Dr. Lakshmi.
Thank you.
Thank you. Bye.
Bye bye, Madhuri. Bye bye. Thank you.